Welcome to Striving for Consensus. Clinical investigators review the current and future role of oral SERDs in the care of patients with ER-positive metastatic breast cancer. This is medical oncologist Dr. Neil Love. For this think tank-style program, I was joined by Dr. Francois-Clement Bidard from the Institut Curie in Paris, France, Dr. Hope Rugo from the City of Hope Comprehensive Cancer Center in Duarte, California, Dr. Rebecca Shatsky from the University of California, San Diego Moores Cancer Center in San Diego, California, and Dr. Seth Wander from the Massachusetts General Hospital in Boston, Massachusetts. To begin, Dr. Shatsky gives a presentation about the optimal approach to biomarker testing for ER-positive metastatic breast cancer.
Today, I'd like to talk a little bit about biomarker testing in estrogen receptor positive metastatic breast cancer, as well as some of the different reasons and mutations of why that's important. The general process of estrogen signaling for hormone-positive breast cancer, which promotes cell growth, survival, is the estradiol, E2, which is sitting in the extracellular domain here. You can see these little orange reddish circles. It translocates into the cytoplasm and it binds the estrogen receptor, which is sitting here in the cytoplasm. And then that entire complex translocates to the nucleus where it binds the estrogen response element, which then proceeds to increase translation and causes tumor growth and cell proliferation and survival of the cancer cells. The way that we generally try to block this is with first-line therapy, is with aromatase inhibitors, which inhibit the production of that ligand so that it can't cause translation and cell survival and promote growth. So that aromatase enzyme converts our natural testosterones, dihydroepiandrosterone, into estradiol. But when we take away that ligand, we block that process. But when cells become smart to us, when cancer finds a way, we develop estrogen resistance. And one of the mechanisms to develop this is by mutating that estrogen receptor so that that E2 ligand doesn't need to bind, so that the estrogen receptor can activate itself sort of independent of that E2 binding. So it makes this conformational change where it doesn't need the E2 binding to translate into the nucleus and cause translation, thereby causing tumor growth. We've found many ways to get around this, but that mutation, that ESR1 mutation that happens, I'm going to talk about in a little bit more detail as we get into talking about selective estrogen receptor degraders. So estrogen receptor mutations, we call them ESR1 mutations. In the inherent setting, when a patient has not been treated with an aromatase inhibitor, they're fairly rare. They're fairly rare de novo to just find in a primary tumor. The prevalence is somewhere between, in different papers that you read, somewhere between 0 and 5% in different data cohorts. And so around 5% max patients will have this just as a mutation in their cancer. But then when we start treating with aromatase inhibitors, we subsequently see that incidence of these ESR1 mutations that allow independent signaling through the estrogen response pathway up to 40% in, again, whichever paper that you are talking about. On this part of the slide, you can see some of the different ligand binding domain mutations, and some of them actually confer more resistance than others, which is interesting, and I'll talk about a little bit more in detail. And then you can see different mutations and different prevalence in which organ you biopsy too, which is very interesting and unique as well. So again, here's the prevalence of ESR1 mutations in untreated, so without aromatase inhibitor treatment versus treated. And so this is also important when we talk about testing for biomarkers and when to test, because it increases as the lines of therapy for anti-estrogen deprivation therapy proceed. So here, as I mentioned before, you can see that If you look at the liver per se in a patient with estrogen positive, HER2 negative metastatic breast cancer, the liver will have a higher proportion of ESR1 altered mutations than if, say, you were looking at the CNS or the brain. Same with the ovary. Lobular breast cancer patients can get metastatic disease to the ovary. And then again, if you're looking at the gene itself, when we're really focused on this ligand binding this domain, and this, you can see the hotspot mutations there, the most common ones, and a particularly nasty mutation, Y537S, affecting that ligand binding domain. So when we talk about the mutations as well, this is in a more detailed picture exactly what's happening here. So E2 being your estradiol in the wild type situation, binding to the estrogen receptor, then translocating into the nucleus and causing translation. And then when you see the ESR1 mutant, say that Y537S or your D538G, it doesn't need the E2 binding. And so it can activate the estrogen response element independently to cause that translation and transcription. So these ligand binding mutations are really the key and most common way that we develop this acquired resistance. And I say acquired because it's really in response to treatment. So cancer always finds a way. It's kind of cancer cells are evolution and in a scale that we can even watch. So depending on what selective pressure we're putting on these cells, that's how they design their resistance mechanisms. So aromatase inhibitors and estrogen-dependent signaling is how we develop these estrogen-dependent resistant mechanisms to become estrogen-independent. And so as you can see, this is a really important part of this presentation, that the prevalence of this mutation increases over time with many different lines of therapy. And so it's really important when we're thinking about biomarker testing that we continue to do that at each line of progression. We're now realizing that if we just test, say, at diagnosis after a patient's been treated in the adjuvant setting with aromatase inhibitors, or if we're just treating after first-line letrozole or anastrozole or exemestane, they may not have an ESR1 mutation at that time, but it doesn't mean that they can't develop it on a subsequent line of therapy. So that is a really important point to realize here, that after your first line of therapy is not the only time you should test for different mutations. And it's not just ESR1. I don't want to forget here to talk about things like PI3 kinase mutations, which can be either an inherent part of the tumor, or they can, in some rare cases, develop as a resistance mechanism, as an upregulated pathway that the cancer has developed in response to treatment. And so we've known about ESR1 mutations as a resistance mechanism for many years now, back in the Bolero-2 trials, which were back in the kind of 2010, 2011 timeframe when we were treating with exemestane and everolimus. You can see here that when you're looking at that population, and even though they're getting an mTOR inhibitor to presumably address maybe some upregulation in that PI3 kinase pathway, if you break it down by mutation here and looking at ESR1 mutations, those patients did worse. They were being treated with an aromatase inhibitor, and when they have these mutations, as you can see by the right-sided graph here, the Y537S and the D538G mutations in that estrogen receptor, those patients had worse progression-free survival over time compared to the wild-type ESR1 gene. So again, here's the SOPHIA trials and the effect combined analysis. When you're giving a patient an aromatase inhibitor, we know that these patients are going to do worse. And importantly here, there is some confirmed resistance in that Y537S mutation, especially when you're talking about fulvestrant. And fulvestrant is a selective estrogen receptor degrader, which we're going to focus on even more in depth with my colleagues' presentations. So you wouldn't think of that causing resistance, but in the that specific mutation, even fulvestrant has a hard time with this mutation. And an oral SERD that can treat independently of that Y537S actually does a better job because fulvestrant is inferior at that point. And so, again, I mentioned that there are multiple different ways that a cell can develop resistance to endocrine therapy here and estrogen resistance. And so we know that the upregulation here becoming estrogen independent is that one of those primary mechanisms that ESR1 mutation, ligand independent or activation of the estrogen response element causes transcription and translation. For 10 plus years now, we've been using these CDK4/6 inhibitors, and that's because these cells are also highly dependent on the cyclin-dependent kinases. And so they will upregulate cyclin D, cyclin 2, 4, 6, and to become resistant to those, they even upregulate cyclin E, cyclin-dependent kinase 2, and that allows them to proceed through the cell cycle and cause transcription and translation as well. In another mechanism is upregulation of the aurora kinase alpha, as well as upregulation of the PI3 kinase pathway here with PI3 kinase, AKT, and mTOR. They can have deletions in the PTEN gene as well. And then, of course, we know that the HER2 pathway, ERBB2 here, is intimately entwined with actual estrogen dependent cell signaling as well. And they can upregulate that pathway as well. And these are all ways that the cancer cell becomes smart to avoid the selective pressure that we're putting on it with our different therapies. Okay, so this is the current NCCN guideline as of April this year. Now, I always describe NCCN guidelines as in progress because, of course, their annual meeting is meeting right now to discuss additional things they should add. But we're talking about biomarker testing here. And assessing for ESR1 mutation has now become part of NCCN and ASCO guidelines. And they say NGS, next generation sequencing, should be done. Now, multiple studies, though, show that if you were doing liquid biopsy, so ctDNA testing, you're more likely to pick up these mutations because, as you saw, different organs express these mutations differentially. And so if you do a survey of the entire blood, so multiple different organs, you're more likely to pick up that ESR1 mutation than you are if you just pick an organ to biopsy. So say you picked the lungs and the ESR1 mutation is not there when you did your solid tumor next generation sequencing. That doesn't mean that other parts of the body, other metastatic sites don't have that mutation. So it really is preferred, and the ASCO guidelines really specify this nicely, that circulating tumor DNA is preferred mechanism for next generation sequencing to have the greatest yield of all of these mutations. And here is the ASCO guidelines. So this was a rapid guideline update from the ASCO Metastatic Biomarker Working Group that says here that ESR1 mutations should be tested for to determine whether a patient has aromatase inhibitor resistance, and that ctDNA is the most effective way to survey the patient. It's also encouraged that this is done on multiple different lines of therapy, not just one time. And so here is just a little bit of an algorithm here. So say you have a diagnosis of MBC. Well, we didn't necessarily look for next generation sequencing on first line previously, but now we have multiple drugs that are approved that can give you treatment options even in the first line of therapy. So it is standard of care as of this year, really, to use next generation sequencing, either with ctDNA or solid tumor or both, at diagnosis and on subsequent line of therapies. So you test for the biomarkers at diagnosis, you treat, the disease progresses, and then you test for your biomarkers again, because again, this opens up multiple different lines of therapy that the patient could have as options for treatment. And even things that can pop up that we didn't think of. We think of PI3 kinase inhibitor or BRCA mutations as being a feature of the cancer, but they can also be mutations that pop up in relation to treatment. So BRCA mutations can be somatic, and they can pop up at any line as well. Same with PI3 kinase mutations, even though that is a more rare. But we want to make sure that we test for these and we don't exclude patients from any potential line of therapy by not testing. Okay, so I'm going to give 2 examples from my clinic that are relevant to this biomarker testing situation. So 72-year-old female, very lovely woman. She was pretty locally advanced when she was first diagnosed with a T2, N2 invasive ductal carcinoma. It was kind of the most typical type of breast cancer, invasive ductal carcinoma, highly estrogen progesterone positive, HER2 negative. That was back in 2013. She was treated with anastrozole for 5 years. I didn't specify there, but she also got chemotherapy. And then in 2025, so many years later, she developed back pain, went to the emergency department appropriately, and was found on CT scans to have innumerable osseous metastatic lesions throughout the spine. We biopsied one of those bone lesions, and it was the same biology. It says lobular here, but clearly it was ductal. I apologize for that. We sent ctDNA at the time of diagnosis, and she had a PI3 kinase E545K, which is a hotspot mutation, very common. And then she was started on first-line ribociclib and letrozole. You know, she didn't have any QTC prolongation, and her LFTs were okay as far as ribociclib use. And it had been a significant amount of time since her last treatment with an aromatase inhibitor. So I was happy to know, since she did get 5 years of therapy, that she didn't have an ESR1 mutation already, which, you know, could certainly happen. It could have been de novo and a pre-existing mechanism of her cancer, but it was not there. So she had a nice classic progression-free survival on CDK4/6 inhibitor of 29 months. So when we talk about eligibility for treatment, elacestrant, and we'll talk about that data a little bit more, seemed like a really nice option. This patient really wanted to do something that was her least toxic option first. She was very, very interested in quality of life. And even though we did talk about PI3 kinase AKT pathway targeting therapies as a possibility, upon progression, she had this Y537S mutation. And so we decided to try elacestrant. And she did really well on that. She tolerated it great. Her disease was controlled, and she had a 9-month progression-free survival, which is also, the kind of best treatment average for this drug. Now, a second case that I have here, 61-year-old female, a little bit more aggressive disease, just at baseline. She had estrogen receptor was about 90%, progesterone was negative, and then her HER2 was 2+ with a FISH negative. So hormone positive breast cancer, but she was T2 and had an oncotype of 30, so more luminal B biology disease, not that luminal A that my long distant metastasis-free survival patient before had. And that was only in 2022, but she got adjuvant TC since she was node negative, anastrozole, and then zoledronic acid as treatment. In 2025, she presented to her PCP with abdominal pain. And while I don't know if this was related to the pain or not, because her liver tumors were fairly small, there was maybe 3 of them and there were 1.7 centimeters. She did have multiple bony lesions and these small liver tumors when her primary care doctor did a CT scan. So she was taking anastrozole when she developed disease, when she was found to have metastatic breast cancer. And when we biopsied the liver, she was found to find same biology breast cancer with very similar receptor staining. So in her, we did ctDNA analysis at the time of diagnosis, and she had this PI3 kinase, another hotspot mutation, very common one, the H1047R. And because we now have a first line therapy for patients exactly in this situation who have PI3 kinase mutations and developed disease on their aromatase inhibitor therapy, we started her on a novel novolisib plus fulvestrant and palbociclib. And she had a 24-month progression-free survival. So while it's a difficult therapy, she did quite well.
So those are two great cases, and we may refer to them when we get into the survey. Just to clarify, though, your first patient, at the time she progressed, she on the SR1, she still had the PIK3 mutation, so she was doubly mutant?
Yes, she was a double mutant on progressions.
And we'll get into, again, the issue with double mutant. I think your point about the fact that she wanted to avoid toxicity certainly would be a consideration. But I want to start with you, Francois, with a question I have, which is about mechanisms and pathology, pathophysiology. But I did a session not too long ago with Dr. Jesselson from Dana-Farber, and she said something very interesting to me that I hadn't heard. I hope I'm correctly stating what her thoughts were, was that she thought that the primary mechanism of fulvestrant and the oral SERDs was actually not degrading the receptor, but competing with the receptor. And I'm curious whether you agree with that, Francois, or not. And also whether or not you think in wild-type patients, SERDs theoretically would have the same activity, an equal activity to some of the conventional hormone therapies we have, AIs, tamoxifen, et cetera. Any comments, Francois?
Yeah, so thanks for the question. So that's an interesting viewpoint. I'd say that, we have some data and about the mechanism of resistance to oral SERDs and also to fulvestrant. And, so far, we don't know what are the mechanisms of resistance to these new drugs. What we know is ESR1 mutations are not driving resistance to SERDs, like the classical SERD, fulvestrant, or oral SERDs, the new one. And what we also know is that, when we treat a patient with ESR1 with an oral SERD, at the end of the treatment, when the patient has experienced a progression, let's say half of them will have an ESR1 still detectable at that time, but also for the other half of the patients, there will be an ESR1 clearance, even though the disease is resisting to the treatment. So which means there are obviously other ways to escape than ESR1 when a patient is treated with a SERD. When it comes also to the, what is the mechanism of resistance involved, it remains to be determined, I would say. And so we have to keep in mind, that ESR1 mutation may still be there, but may not drive the resistance to oral SERDs when detected at progression. So I would rather see the mutation as a, let's say, one target that will be acquired during the treatment, but then, after a SERD will become, let's say, less relevant.
So Hope, when I first heard about fulvestrant, it made a lot of sense. It got rid of the receptor. Now you have the SERDs doing the same thing. But is that really the mechanism of why you see anti-tumor activity, or is it more a competitive mechanism?
That's a good question. And I think, drug development is such an odd thing. I mean, it made a lot of sense about fulvestrant, and then it turned out, the drug dosing wasn't even figured out correctly. Unlike Optimus, it was too low a dose, and it took too long to get to steady state. And we get over that with the oral drugs now. So that's at least an encouraging part. But I think, what we're doing is not competing with the estrogen receptor because you're not blocking it, right? You're taking it away. You're degrading the estrogen receptor, or you're blocking a processing mechanism necessary for the estrogen receptor. Ubiquitination, for example. I think, competing would be if you were going to block the receptor itself, right? But in this situation, you're really causing degradation. But what's interesting is when you stop the drug, the estrogen receptor comes back again. So this is a fascinating area, but it does lead us to the whole idea of degrading the estrogen receptor, which is a fascinating idea. And I think, The idea about how you degrade the estrogen receptor also is different. These agents have different mechanisms in preclinical studies, and different degrees of degradation, and how quickly the estrogen receptor can recoup itself, and whether or not it's constitutively active, which is the issue with the ESR1 mutation. So it's complicated, and what happens in people is even more different. And as Francois mentioned, I think that we don't understand those mechanisms of resistance as well as we really should.
So, final comment from Rebecca, then we'll move on.
One thing that I think it's important that the community know, as some of the evidence of estrogen receptor degrader, is if you do a biopsy of a patient who's been on fulvestrant, or say you did a neoadjuvant SERD trial, and we've done some of these, on surgical pathology, you'll see that the estrogen receptor staining is much lower. And it's not that the patient's suddenly triple negative, that their biology has drastically changed into a basal subtype or something like that. That's the effect of the drug that we can literally see on the receptor staining. And so I think in metastatic setting, a lot of people, when they rebiopsy, get pretty nervous right after fulvestrant treatment that now they have triple negative disease. But I do want to kind of reinforce that that's not some kind of drastic change as far as the underlying molecular biology necessarily. It's the effect of the drug. And like Hope said, they do grow back.
That's so interesting. What an important practical point. So again, we may come back to some of these later, but let's move on now. And Seth, we're going to get specifically in some of the data we have on SERDs.
Great. Thank you, Neil. Always a pleasure. Appreciate the invitation. Great to be with everybody today. So our next talk today is going to be about the role of oral SERDs as monotherapy in ER-positive, HER2-negative metastatic disease. And so I wanted to break this down sort of in three sections here. First, I'll just spend a moment and comment on the structural and functional considerations related to fulvestrant and emerging SERDs, although we did just briefly cover some of this really important conceptual framework. And then I'll show you evolving data for oral SERD monotherapy, both positive and negative in the phase 2 and 3 setting. And then I'll finish by thinking a little bit more about engaging the target and thinking about how we can actually look at dynamic changes in ESR1 and the type of ESR1, the variant of ESR1, and how that might reflect clinical outcome for using these drugs. So this was a really nice review from a few years ago looking at the mechanisms of the different antiestrogens, both that we are used to using in clinic as well as some of the emerging agents. As we've already been talking a little bit about, the aromatase inhibitors deplete the body of the ligand estrogen, whereas the selective estrogen receptor modulators bind to the estrogen receptor and alter its function in a tissue-specific way, either as an agonist or an antagonist. And we're focusing today on the selective estrogen receptor degraders, which again conceptually bind to the receptor and help target for degradation, though there are, as we were just discussing, other elements to this in terms of blocking the function of the receptor itself. I do just briefly want to mention that there are some other novel agents in active and late phase clinical development, including the proteolysis targeting chimeras, which also really effectively degrade the protein, as well as the CERANs, complete ER antagonist, and the SERCAs, selective ER covalent antagonist. This is a nice review of the mechanisms of these drugs, but today we're going to focus on the SERDs. And these are the organic structures. We all think we've escaped, organic chemistry completely, but it does sometimes come back to haunt us, even in our current work. You can see there are some structural differences between these drugs. We have the novel oral SERDs on the left-hand side and fulvestrant on the top. And we've been discussing a little bit some of the differences between fulvestrant and these emerging agents. Broadly speaking, these newer oral SERDs have enhanced bioavailability. Of course, they're oral, and so the patient doesn't have to go through painful intramuscular injections every few weeks. They have increased affinity for binding to the ER, the novel oral SERDs, compared to fulvestrant. And of course, they have increased activity in preclinical models of endocrine resistance, including with many of the ESR1 variants that we'll see today. Now, of course, when we're talking about oral SERDs in clinic, we have to start with the EMERALD study. This was really an important prospective phase 3 paradigm shifting study led by Dr. Bidard, who we're going to hear from in a moment. And here, I just want to highlight a couple things about the trial that people may not think of when they first consider the study. We're going to look at a number of different studies today for these drugs, and I want to highlight that EMERALD really had a very high degree of pretreatment for these patients compared to some of the studies that came subsequently. So these were for patients who were allowed to have had 1 to 2 prior lines of endocrine therapy. They had to have progression on a CDK4/6 inhibitor, and they were allowed to have had prior chemotherapy. And that resulted in, I would argue, a more heavily pretreated population. So 20 to 25% of patients on EMERALD had chemo in each arm. Almost half of the patients had ESR1 mutations, again, because these were a little bit later line. And 40 to 50% of the patients had had 2 prior lines of endocrine therapy. So we want to keep these metrics in our head as we look at some of the other data coming for some of the other SERDs momentarily. Almost 500 patients were randomized to endocrine therapy of clinician choice or the oral SERD elacestrant. And here are the curves, and we've been thinking about these curves now for a couple of years. And of course, there's this important pattern that's emerging for many of these second and third line anti-estrogen studies, where we see a steep drop in the curve. Anywhere from 20 to 40% of the patients, regardless of which line they're in, are completely refractory to endocrine therapy. And then in the middle of the curve, there's a little bit of a separation with some modest benefit. And then there's a tail where at least 10 to 20% of these patients are doing really well on endocrine monotherapy, better on elacestrant, but even some of these patients are doing okay on fulvestrant. And I'll come back to this pattern as we think about mechanisms of response and resistance. So the ITT population here, small benefit at 1.9 to 2.8 months. But when you look at the subpopulation who have ESR1 mutation, we see a bigger separation in the curves from about 1.9 to almost 4 months. And based on this data, the drug was approved in endocrine refractory metastatic patients who have ESR1 mutations in the US. The team went on to look at specific subgroups, not just based upon the presence or absence of ESR1, but based upon the duration of their frontline endocrine and CDK4/6 inhibitor therapy, at least 6 versus 12 versus 18 months. And as we can see, when we look at patients who had a longer duration on their first line AI CDK, the curves begin to separate a little bit further. So these are ESR1 mutant population with at least 12 months of first line benefit on CDK4/6 inhibitor based therapy. Now we have an improvement from about 1.9 months in the control arm to almost 9 months in the intervention arm. And to me and to I think many oncologists across the country, this is really a more meaningful and clinically actionable benefit that we're seeing. And I think this is how we're seeing these drugs deployed in practice right now, based both on the mutational profile and also, as we heard from Rebecca's case, based on their magnitude and duration of benefit on frontline endocrine therapy. Now, we did an analysis with our colleagues at Guardant looking at a very large real-world clinical genomic database to try to see how elacestrant was being deployed in clinical practice and what the magnitude of benefit was in this more heterogeneous real-world population. So the Guardant Informed database has over 24,000 patients with breast cancer, where we have claims data looking at which drugs they were on and how long they were on the drug, linked to genomic test results based on Guardant circulating tumor DNA. So we looked at patients who had ESR1 mutations and exposure to elacestrant after FDA approval, and we said that they had to have the ctDNA test within 6 months of receiving the drug so that we could have a somewhat accurate picture of what their clinical benefits were. We had over 700 patients. The vast majority had prior CDK inhibitor. More than 50% of them had prior fulvestrant, and almost 40% had prior chemotherapy. So again, a pretty heavily pretreated population, and you can see that there on the right. And in our real-world data set, the median time to next treatment was over 6 months. And this is what people are actually experiencing in clinical practice. Again, lining up very nicely with the case that Rebecca shared with us a moment ago. And when we broke this down by line of therapy, there was a numerical benefit, longer time on elacestrant if they had less than 1 prior line of therapy, meaning this was like second line population, but it wasn't statistically significant. So even those patients in the second or third line were still getting 6 to 7 months of benefit, again, numerically slightly longer if they were really purely in an earlier line of therapy. And you can see those curves here on the right. Now, I wanted to turn to some of the other more recent phase 3 data for oral SERDs. This is imlunestrant from the EMBER-3 trial. Similar, but look at some of the important differences here compared to EMERALD. No prior chemotherapy allowed, only one prior line of endocrine therapy, and 40% of these patients were CDK4/6 inhibitor naive, so a much less heavily pretreated population. The frequency of ESR1 mutation here was about 35 to 42% between the different monotherapy arms. Patients were randomized to endocrine therapy of clinician choice versus imlunestrant, and then later we saw a doublet arm added with imlunestrant and abemaciclib that I believe we'll hear about from Dr. Bidard in a few moments. Look at the shape of these curves. They look almost identical in terms of their structure to what we saw in EMERALD. A steep drop, a little bit of a separation, and then a tail, and there was really no benefit in the ITT population, only a modest amount of benefit in the population that carries the ESR1 mutation from about 3.8 to 5.5 months. So looking very similar to what we saw with EMERALD, slightly better numerically because they were less heavily pretreated. And then here's SERENA-2. This is a phase 2, very similar study looking at camizestrant versus fulvestrant. There were several doses of camizestrant utilized here. They had to have had at least one prior line of endocrine therapy. They were allowed to have had up to one prior line of chemo. And again, on the bottom, looking at these curves, in the population with no ESR1 mutation, we really didn't see a benefit here. But in the population that had the ESR1 mutation, it went from about 2 months in the control arm with the very steep drop with fulvestrant and shifting up to about 6 to 9 months in the patients who had ESR1 mutation and received various doses of camizestrant monotherapy. So we saw real activity here for camizestrant. And then we come to SERENA-6. I'm just going to briefly introduce this because we're going to, I think, hear more about this from Dr. Bidard. It sort of falls between our topics of monotherapy focusing on the SERD, but doublet strategies moving forward. This is a really innovative and brilliantly designed study. Patients on first-line AI-CDK are being monitored for emergence of ESR1. If they have a new ESR1 mutation but no clinical or radiographic progression, they're randomized to continue their current therapy or switch to camizestrant with the same CDK inhibitor. And we saw these data just recently at ASCO, where you see an improvement in median PFS1 from about 9 months to 16 months with a really significant hazard ratio, and an even more impressive benefit in time to deterioration in quality of life. Now, there were 300 plus patients randomized. The median time to randomization was about 23 months. Most of these patients had palbo, as would be expected. Interestingly, the ESR1 mutation was detected when the patient came on study, which could have been at any time, in over half the patients on the first test. So I would argue, and we can talk a little more about this during the discussion, that there may actually be an underestimate of the benefit here. We may have been able to detect the ESR1 earlier in more than half of these patients. We need to see more mature PFS2 and OS data. And of course, there are some important barriers that I'm sure we'll discuss in terms of clinical integration, cost, and thinking about doublets in the future, other novel doublets. I just want to briefly mention 2 negative studies. We have the Acelera phase 2 study, very similar to the monotherapy studies we've been discussing. Overall population, endocrine therapy of clinician choice versus giredestrant with no benefit in the ITT and a trend toward benefit in the ESR1 mutant subpopulation, but this was viewed overall as a negative study. And then here we have the AMEERA-3 study, phase 2, very similar, endocrine therapy of clinician choice versus amcinestrant, another oral SERD. And again, here, no benefit in the ITT and a trend, insignificant, but a trend toward improvement in the patients with ESR1 mutation. Now, giredestrant is still under active development in a number of important studies looking at doublet therapies that we can discuss in a few moments. Amcinestrant was discontinued, so is not under active clinical development. And I just want to end with a couple of slides on this idea of thinking about the importance of the type of ESR1 variant and what we might learn by monitoring ESR1. So as Rebecca was nicely outlining, not all ESR1 mutations are made the same, and the Y537S particularly has some difficult to treat features, both in preclinical models and in the clinic. This is a nice study from Cancer Discovery a few years ago showing that in the wild type and in the D538G ESR1 population, when you treat these mice with either fulvestrant or with a next generation oral SERD in orange and in red, you see good benefit for both. But when you look at the Y537S, you really have to move to red. You have to move to the next generation oral SERD. You don't get nearly as much benefit for fulvestrant. And we see this also in clinical data sets. For example, we demonstrated the same phenomenon in postmonarch. And then here is subpopulation data from Emerald looking at D538G on the left and Y537S on the right. And you can see elacestrant is performing well in both populations. You're getting improvements from just under 2 months to over 9 months. And it didn't matter which type of ESR1 mutation the patient had, as long as they'd had at least 12 months on their prior endocrine therapy. So this also suggests that elacestrant in patients is working well regardless of the ESR1 variant. We saw the same thing in our real-world data. So we looked at Y537S versus all other mutations in the Guardant database, and there was no significant difference in outcome. All of these patients were getting between 6 and 7 months when you looked across the cohort. One thing we did notice in the real-world data that was interesting is polyclonality. So if you had one ESR1 mutation versus 2 or 3 versus 4 or more, so a smaller group of patients with many different variants in ESR1, as you got up into that higher number, closer to 4, you started to see a decrease in the amount of clinical benefit, dropping by a couple of months in the real world data. So this is the first sign, to my knowledge, that high degrees of polyclonality, more different ESR1 variants, might portend a worse outcome, at least on monotherapy in the real world setting. And then this was a beautiful data from phase 1 experience with imlunestrant, where the authors assigned the concept of molecular response. So patients who started imlunestrant monotherapy, and then 1 month later, after one cycle, they looked at the amount of ESR1 present in the blood. If there was more than 50% decrease in allelic fraction, they were responders. And if there was less than 50%, they were called non-responders. And look at the way these curves separated. The red curve are the patients who lacked a deep response based on circulating tumor DNA. The gray curve are the patients who had a deeper response, and there was a big separation in PFS probability. And on the right-hand side, you can see, regardless of the type of mutation, 74+% of patients had a decrease, but a smaller number, 15 to 20%, actually didn't respond. They had an increase in the amount of ESR1 in the blood, and we need to learn what's going on with those patients. So this is where I think the current landscape sits right now. I have to change this slide, Neil. I think every 12 weeks we have a new data or new approval. This is the first line setting. We're mostly using an AI with ribo because of the survival data. We just spoke a moment ago about the ANOVA 120 population for those people recurring on endocrine therapy who have PIK3CA mutations. And look how complex the second line is getting. You can use alpelisib or capivasertib for PI3K pathway alterations. You can use elacestrant for ESR1. We, of course, have PARP inhibitors for BRCA mutations. We have fulvestrant kind of plus or minus, either abemaciclib or everolimus for patients with none of the above. We have new data for camizestrant, vepdegestrant, imlunestrant, but we don't have FDA approvals yet. And then in the third line, of course, we have ADCs, we have chemo, et cetera. So lots of stuff going on. And we just speculated at ASCO about this. The shape of this curve, we want to have better biomarkers to predict response. We have to be able to identify who are the rapid progressors, the people who fall off the curve. Who are the people on the green who are living on that tail who could do well on oral monotherapy for years? And who are the people in the middle who would get a little bit of benefit from endocrine therapy, but really need better doublets with PI3K, with AKT, with next-gen CDK? So we need better composite biomarkers to help design clinical trials and pick the right people to fall into these groups. So to conclude, we see the second generation oral SERDs have good bioavailability and ER affinity. We see elacestrant, camizestrant, imlunestrant have activity as a single agent in the ESR1 mutant subpopulation. These drugs are well tolerated. I think Hope is going to tell us about this momentarily. We see dynamic ctDNA monitoring can show us about response an ESR1 dependent resistance, and it may be clinically actionable based on SERENA-6. And we saw negative data for amcinestrant and giredestrant as monotherapy. Fulvestrant is limited for ESR1, while the oral SERDs have more activity here. We're looking at doublets and triplets that we'll hear about in a moment. I'd like to think about, what's the best approach for patients with multiple targets, right? The dual mutants, and in the future we'll have more than 2 targets. And then how are we going to use on-treatment ctDNA in clinic today, right? Based on SERENA-6 and PADA-1 and other experiences coming up in the future. And we're going to look at these multi-gene and transcriptional signatures to help predict ER dependence and to better personalize therapy for these patients in the second and third line setting. So let me give you my 2 cases here. First, similar, I think, to the case Rebecca shared with us, a 65-year-old patient, pretty healthy, hypertension, hyperlipidemia, comes in with hip pain and a breast mass, good performance status. So she has a 4-centimeter right breast lesion and widespread bony mets. PET CT was negative for visceral disease. So this is really a de novo metastatic, bone-only, untreated patient. Biopsy confirmed ER/PR strongly positive, HER2 1+. The baseline ctDNA was negative with a low tumor burden and stable microsatellite. So we started her on letrozole and ribo, and like many of these untreated bone-only patients, she did very well for years. 4 years, she had a drop in tumor markers, improvement in her symptoms, sclerotic changes on the CT, reduction in the breast mass. But then after several years, the PET scan shows new lesions in the bone and a couple of small liver lesions with normal liver tests. Now we repeat the ctDNA. She's got a D538G, ESR1 at a variant allele fraction of 3.2% and a cyclin E amplification. So we opted, based on the data we discussed and the rationale from the case we had reviewed previously, to try elacestrant, and she's doing well. Had a response in tumor markers, improvement on the PET, and she's been getting treatment now for over 6 to 9 months. The second patient, a little bit more challenging, 53-year-old patient, again, healthy, good performance status. So she had a prior T1N1 ER-positive, HER2-negative breast cancer, had surgery, adjuvant TC, radiation, and 5 years of letrozole, and she's now been off treatment for 3 years. So she opted to discontinue at that time. She comes in with new alkaline phosphatase elevation, eventually gets scans that shows bone, lung, and some mediastinal disease. She has an EBUS and a biopsy that shows, again, kind of luminal B, ER positive, PR negative, HER2 negative, IHC of 0. ctDNA at this recurrent metastatic disease has a PIK3CA with a high allelic fraction, about 30 to 40%, and a P10 deletion. So she goes, because she's been off therapy now for a number of years, back on an AI with ribo and does well, but not as well as the other patients. So this patient gets about 12 to 18 months, has stable disease, but no great response. We didn't see the deep drop in the tumor markers or the sclerotic changes that we did on the last patient. She eventually progresses, now new liver, lung, and bone lesions. And with a repeat ctDNA, she has the truncal PIK3CA, now P10 deletion, an RB variant, and polyclonal ESR1, multiple variants spanning different allelic fractions from less than 1% up to about 4%. And so again, we're having this discussion. We have multiple targets here. Do we offer a PI3K or an AKT inhibitor? And if so, which one? Do we offer her a SERD monotherapy? Given the status of her disease and the targets, we decided to give her fulvestrant and Capiva, and she's had some improvement and is having a response right now for about 6 months.
So that was a great presentation, very interesting cases. Just one quick thing, and it kind of relates to Hope's talk and also some of the data we're going to look at. So both of these cases and also Rebecca's cases, I'm curious about how they tolerated treatment. So both of you had a patient on elacestrant. I'm going to be curious to know any tolerability issues, particularly interested in GI. I'm trying to get more of a granular feeling about what happens to these people. And then Rebecca, your patient got the triplet with inavolisib, and Seth, your patient got capi plus fulvestrant. I'm curious how they tolerated that. So I'll start with you, Rebecca. How did your patient do on fulvestrant, and how did they do on the triplet?
On the triplet, it was tough. So that was on a clinical trial when this was first being done, and the stomatitis was an issue. We started dexamethasone mouthwash, but still that was tough, and we had dose reductions for sure. the blood sugar monitoring is cumbersome. You need very close blood sugar monitoring on inavolisib. I'm never too concerned about cytopenias as far as CDK4/6 inhibitors because those of us who use them constantly, they don't seem to get more infections. And while you have to dose reduce a lot on a clinical trial out of necessity, that not as much a concern, but really the stomatitis, blood sugar monitoring, the diet to maintain a low blood sugar on a drug like inavolisib, which is similar to using alpelisib, those can be cumbersome.
How about your patient on elacestrant?
Yeah, so definitely what I would call significant dyspepsia. And that's what a lot of people describe to me as like their stomach feels sour. And so it's not as much classic nausea as they feel like their stomach feels sour and that they kind of get nausea because of this deep feeling in their stomach. And so the first 2 months are always hardest with that, but with some supportive medicines, we did okay.
So again, Seth, how did your patient do on elacestrant, and how about with the CAPI?
Yeah, I think my experience across the board with multiple oral SERDs, including in this patient, she did pretty well. And for some of my patients in the adjuvant setting who are putting on some of these higher risk adjuvant trials who have really struggled with joint discomfort and really significant menopausal symptoms, when we move them to the oral SERDs, they've actually felt a lot better overall. I do agree that there is some signal for GI. Most of it, in my experience, has been low grade, like a little bit of nausea, as Rebecca was just describing. I don't think I've ever had to stop an oral SERD for GI toxicity in my experience. A lot of patients who are doing well on standard endocrine therapy do kind of equally well on the oral SERDs, and some of the patients who are struggling on standard endocrine therapy actually do better on the oral SERDs in my own anecdotal experience.
How about the CAPI?
Yeah, she did well, and CAPI is interesting. I think it's probably the easiest to give of all the PI3K pathway targeted agents right now. Part of that, Inova has a little bit of a disadvantage being in a triplet, as we just talked about. I wonder what an Inova doublet would look like compared to CAPI. CAPI certainly is a lot easier to give than alpelisib. Again, we run into sometimes a little bit of GI stuff, occasionally rash, occasionally hyperglycemia, but this patient did well. We obviously do enhanced monitoring at the beginning. We didn't need to do any dose reductions. And I would say the magnitude of some of the challenges we've had with CAPI have been less than some of the first generation PI3K inhibitors.
So we'll also get into that when we get into the survey, some interesting findings there. But let's move on now, and Francois is going to talk about some novel applications of oral SERDs. Francois?
Yes, thank you very much. So today, it's my pleasure to address the potential novel application of oral SERDs. And for that, so this is the outline of the talk. So we will first address the oral SERDs given in combination with other drugs. So we'll go through the rationale, the phase 1 results, and the 2 main phase 3 results that we have at the moment, which are MBES-3 and SERENA-6. Then we'll touch on ongoing adjuvant trials with no result at the moment, and we'll end up with 2 clinical cases. So to start with, the question is, what is the purpose of combining oral SERDs with, any other targeted therapy? And here, I think that, the concept is coming by, we could leverage additive or synergistic effect by combining this endocrine agent with other targeted therapy in very similarly to what has been done with fulvestrant. So we have 2, let's say, objectives here. One is to extend disease control, which means to get longer PFS, but also, and it's very interesting, is also to broaden the target population. So as we have seen with this talk, most of the activity as a single agent has been demonstrated in patients with ESR1 mutation. So here the idea is by combining the oral SERD with another drug, which may depend on another biomarker. When you combine both agents, at the end you're very likely to dilute the impact of ESR1 mutation status on the study results. So meaning your study could could be positive in all populations. A combo could be active in a broader population. So obviously the key combo partners are CDK4/6 inhibitors because of their key role in the first-line metastatic setting, but also in the adjuvant setting, and also a combination with PIK3CA pathway inhibitor. So, but having said that, I think we have let's say good level of evidence supporting that fulvestrant can easily be combined with basically potentially any drug. But it's quite different from all SERDs, and we have seen some drug-drug interaction in the past with these agents, so which means we really need phase 1 results. And so now we have many results of phase 1 trials. So here I listed let's say the main oral SERDs, so camizestrant, elacestrant, giredestrant, and imlunestrant. And you see that each of these drugs, they follow their own strategy, but at the end, what you could see is that, in terms of phase 1 data, we have phase 1 data for a combination between an oral SERD and palbo, abema, and ribociclib for camizestrant, elacestrant, and giredestrant. And when it comes to phase 3 data, so we have one phase 3 with SERENA-6, where camizestrant was combined with any of the 3 CDK4/6 inhibitors, so we chose the safety and tolerability of the combination, and we have another phase 3 with imlunestrant combined with abemaciclib. So overall, I would say that all these studies have shown so far the feasibility of combo therapy and with, let's say, consistent adverse event profile. But I'm going to show you some more results here. So we'll start with imlunestrant. So the AMBER trial suite. So AMBER 1 was a phase 1 trial in which imlunestrant was investigated as a single agent, but also given in combination with many agents. And here we have a recent publication showing the results in terms of efficacy of imlunestrant as a single agent, imlunestrant given with abemaciclib, and imlunestrant given in triplet combination with, say, explored abemaciclib and AI as a partner. So it's obviously interesting when you look in terms of waterfall plots that you see they had more response in patients receiving imlunestrant and abemaciclib, so better overall response rate, better CBR, and other clinical endpoints. So obviously suggesting that even in patients pretreated with CDK4/6 inhibitor, combination of imlunestrant plus abemaciclib could be superior to imlunestrant alone. And building on this AMBER 1 trial, so we had these AMBER 3 trials that has been reported and published earlier this year. And this already touched upon on the single arm combination. So single endocrine therapy versus single agent imlunestrant, but they also had another comparison in the trials, so comparing patients receiving imlunestrant versus those receiving imlunestrant plus abemaciclib. So it was a 3-arm trial. And here, clearly, the idea was to test the impact of the CDK4/6 re-challenge after progression, keeping in mind that about 2/3 of patients in the trial were already treated with a CDK4/6 inhibitor, and 1/3 of the patients were CDK4/6 naive. So it's a mix of re-challenge and first exposure to CDK4/6 in this combo arm. If you move to the results, the efficacy was very interesting, I would say. And it's a large phase 3 trial that is showing that in patients who some of them have been pretreated with CDK4/6 inhibitors, so it's really showing the benefit of using abemaciclib after another CDK4/6, and most patients received either palbociclib or ribociclib as a first line. So it's really going in the same way that the post-MONARCH study. And so it's a second phase 3 trial showing the benefit and the interest of having abemaciclib as an option for the second line trial. So when it comes to the PFS, so we have longer PFS with the combo compared to the single agent. And it was true in all subgroups. As I mentioned, it's not only the ESR1 mutated patient who benefited from the combo strategy, but all patients. So the efficacy was much broader than just the core ESR1 population. So obviously, very interesting data. OS was immature, so which means we need a bit of more follow-up to see whether it will be registered or not. When it comes to safety, I'm going to be very quick because Dr. Rugo will discuss this part, but just to say that imlunestrant has very little toxicity on its own, and when combined with abemaciclib, obviously what you get is the toxicity of abemaciclib, which is well known. So nothing much to say about this. Elacestrant. So elacestrant also was the first-in-class SERD, and so they are also trying to build combination strategy. And here the Elevate phase 1 trial showed that elacestrant could be combined with everolimus or ribociclib. At the moment, there is no phase 3 trial testing this combination, but there could be some coming because of this safety data. So phase 1 with camizestrant, so which is your old SERD, that has been investigated in SERENA-1. And here, so camizestrant was tested with abemaciclib, palbociclib, and ribociclib, and it was tested at 2 doses. So 75 milligram for camizestrant and also 150 milligram, which was, let's say, investigational dose. So in all trial with camizestrant, the dose of camizestrant is 75 milligram. And what they've shown here in terms of overall response rate, CBR and median PFS is very aligned with other results we had in the field, so showing activity and, most importantly for a phase 1 trial, tolerability, especially in combination with ribociclib, so meaning that there was no cardiac safety issue when combining camizestrant and ribociclib. This has led to the original design of SERENA-6, as already presented by Dr. Wander. So SERENA-6 is the first-line trial. So patients were receiving their first-line treatment, AI plus CDK4/6, and they were also monitored for the appearance of ESR1 mutation during the treatment and before disease progression. So patients were doing perfectly well. They had regular CT scan, no disease progression. But at some point, as soon as you detect ESR1 mutation, so patient could be switched to camizestrant while the CDK4/6 partner was maintained. And in this phase 3 trial, so all CDK4/6 were allowed, so which means camizestrant could be combined with palbo, ribo, or abema. And so this is a patient population shown here. What is interesting, as pointed out by Dr. Wander, is that many patients were randomized just on basis on the first test, so showing that you could actually detect a lot of ESR1 mutation when you test during the first-line trial. In terms of efficacy, the slides, the results have been already shown by Dr. Wander. So again, very good result in terms of PFS hazard ratio 0.44, which is rarely seen. And very interestingly, I would say, is the early separation of the two PFS curves. And that is very critical. So which means it's not something that you could get in second line when you have a steep decrease at the first 2 months. Here, like all patients could, let's say, get a chance to get the benefit of camizestrant. So it's very early separation of the two curves. So and constant hazard ratio over time. When it comes to the key other argument in favor of the strategy is the quality of life. Obviously, a huge impact. Usually, new drugs do not alter the quality of life. Here, it's more like quality of life is improved or at least is kept at the same level. So a longer time to quality of life deterioration with the strategy. So patients are doing well and they are still well under your treatment. When it comes to safety, this will be likely covered by Dr. Rugo, but obviously no signal of additional toxicity. There was an additional increase in absolute number in terms of hematological side effect, but this is because patients were kept longer on CDK4/6, and we know that these agents are giving some hematological toxicity. So now moving to the adjuvant phase 3 trials. These trials are ongoing, so we have no result to share, so it's just a one slide here. So we have different designs. So the first classical design is an upfront comparison. So patients have undergone surgery, chemotherapy, radiation therapy maybe, and they are randomized between standard endocrine therapy versus an oral SERD. So it's really like head-to-head comparison, frontline. We have 2 trials, lidERA and Cambria-2, and according to clinicaltrial.gov, the primary readout of lidERA should be, let's say, earlier next year. When we move to the next kind of design, so we have late switch design. We have 3 trials. So one with camizestrant, one with imlunestrant, one with elacestrant. So these trials are super large adjuvant trial. You see that the EMBER-4 trial will enroll up to 8,000 patients. So very big trial. And these trials are expected to read out in 2027. And the last trial, which is interesting, is tracking the appearance of ctDNA, and like say any ctDNA, not only ESR1. And if ctDNA becomes positive in patients in the adjuvant setting, so patients are randomized between staying on same treatment or being switched to elacestrant. Based on this, I will move to the case presentation and have 2 cases. So first case is, let's say, to discuss what is the interest of imlunestrant and abemaciclib. Of course, it is approved. If it is approved, currently it's not approved. So the case is about a 55-year-old woman. She is a sales representative, so working in public, and she has been diagnosed with an ER+2 negative breast cancer, de novo lymph node, and bone mets. NGS on tumor tissue diagnosis shown PIK3CA mutation, no BRCA mutation at the somatic level, and she received letrozole ribo as first line. And she was doing well and was still working, and so that's very good for her. But after 1 year and a half, she had some bone pain, and she had a disease progression, showing new liver mets and also progression in bones. Now, at the moment, she's PPS1, so because of the bone pain, and she's seeking a second opinion about her option for her next line. So if we think about, what we could offer, and here, we could think to mutation agnostic endocrine therapy options, fulvestrant as a single agent, fulvestrant abema, fulvestrant evero, imlunestrant abemaciclib. We also can think to mutation-driven endocrine therapy options, fulvestrant capi, fulvestrant alpelisib. If she has an ESR1 mutation and testing needs to be done, then the patient could be eligible to elacestrant or imlunestrant given as single agent. And we also have the chemotherapy. So how to navigate between these options. So these are my proposal, and I hope that the faculty would agree with this. So I would say that we could get rid of some of these proposals here that, telling that data suggests at least indirectly a lower efficacy. Fulvestrant is likely lower than fulvestrant given in combination. Fulvestrant abema is likely less effective than imlunestrant plus abema. And obviously, imlunestrant single agent is less effective as compared to imlunestrant plus abema. So we could get rid of a few of these options. Then, in terms of level of evidence, we have also to think in terms of level of evidence. We have limited level of evidence after CDK4/6 for alpelisib and also for everolimus given in combination with fulvestrant. And so when it comes to chemotherapy and ADC, obviously, as I mentioned, so the patient has a good performance status, no visceral crisis. So obviously, it's not the time to propose a chemotherapy. We could postpone the use of chemotherapy and ADC a bit later. So that is leaving us with 2 options, imlunestrant plus abema versus fulvestrant plus capivasertib in this patient with a known PIK3CA mutation. And what is the final decision as a second-line treatment? I let it very open. Be based on comorbidity, tolerance profile, and it will include, as we discussed, HCP experience in managing the adverse events of abema on one hand and capivasertib on the other hand. Also compatibility with the daily life. She was working, so she probably intend to work a bit more. And of course, route of administration when it comes to imlunestrant versus fulvestrant. So all of these aspects have to be discussed with patients. Then moving to the second case. The second case is actually the same as the first case. But what we have done here in this patient is that we have implemented ESR1 monitoring during the first line. So which means in this same patient, so that patient who would have experienced a disease progression after 18 months and have back pain and, options with limited tolerability. Here for this patient, we were able to find an ESR1 mutation found by ctDNA monitoring, and the patient was doing very well and still working at that time. So what is your option then? When you know that a patient has a rising ESR1 mutation, that you know that your AI agent is unlikely to work, for a long time, your only option, I would say, is to change the endocrine therapy to regain efficacy on ESR1 mutation. And then, if camizestrant and CDK4/6 is approved, then I would consider switching to and prescribing camizestrant instead of letrozole, and we would continue with ribo. In this case, is really showing like the very major advantage of the SERDs strategy is that it's a seamless modification of the first-line therapy. So it allows a longer efficacy, excellent tolerability. It delays the onset of symptoms, deterioration quality of life, and it allows to keep patient at work and to, so the patient are still working, they can keep their medical coverage, and that could be very relevant for the patient. And although when we speak in terms of strategy, I would say that this strategy also allows to offer to the patient a PIK3CA targeting agent later on when she will experience a disease progression. So the patient could have received the oral SERD and a PIK3CA targeting agent. So no choice to make between the two targets. Thank you.
So these are, what a great presentation, and the two cases are so provocative. We could spend a lot of time talking about that, but maybe in general, keep these cases in mind when we get into the survey where we deal with situations like this. But just a couple of questions. One, Rebecca, any brief comments about these clinical scenarios, but also what's the rationale for looking at adjuvant SERD when presumably you're not going to be seeing ESR1 mutation? It kind of gets back to my original question. When we talk about the fact that in patients who were wild type, quote, didn't benefit, we're saying compared to fulvestrant. But even though these weren't equivalency studies, can you say it was equivalent to a fulvestrant? And in using it in an adjuvant trial, are you saying that you expect that there would be significant activity? Because I assume you're not going to see SR1 mutations, Rebecca.
Yeah, so I think that's a really important point, is that the bar for fulvestrant versus oral SERDs, I think for a lot of us was at least replacement, because fulvestrant is painful and they have to be tied to an infusion center, which really changes their life. And they get these chronic granulomas in their hips that can hit nerves and things. And so it's not that the oral SERDs don't have activity in wild type scenarios. It's that they were measuring for, superiority in that setting. And so when we're talking about these in the adjuvant setting, as we said before, up to 5% will have, without treatment, a aromatase inhibitor, an ESR1 mutation that is part of their cancer. But during treatment with aromatase inhibitors, we haven't studied this too well in the curative setting before, but certainly a percentage of them during treatment do develop ESR1 mutations. And I see that every day in my practice. I just had a new metastatic patient who, first diagnosis of metastatic disease. She's about 3 years out from her aromatase inhibitor therapy. She got treated with about 6 years, and she certainly had ESR1 mutation at the start, at diagnosis. So they don't only develop it on. And so the idea with some of these aromatase inhibitor to oral SERD adjuvant studies is that we're catching all of them that could have, developed resistance, and that maybe in the wild type population, these are more tolerable drugs too. They might have slightly better efficacy, but I kind of agree with Dr. Wander that their joint pain seem to be a bit better in my population, because I do have the Cambria 1 and Cambria 2 trials open right now. And some of the tolerability of the oral SERDs, there's pluses and minuses, of course, to both. Some of them might be even more tolerable. And if they're equivalent to the aromatase inhibitors, at least, and catch a population of patients who are developing resistance or have that de novo mutation, then that could be more effective than an aromatase inhibitor.
So I'm going to move on in a second to Hope's talk, but just one final point back to you, Seth. I don't know whether you're participating in any of the adjuvant trials, but would you have any ethical concerns about randomizing a patient to a SERD in the adjuvant setting?
Yeah, thanks, Neil. We're participating in EMBER-4 and Elegant, and I agree with all the comments that Rebecca just made. I think also philosophically, it's very interesting. Francois-Clement's data from both the PADA-1 and SERENA-6 experience suggests that early intervention matters. Now, the philosophic question, and which is hard to prove scientifically, is can you intervene even before you can detect it to prevent that mechanism of resistance from emerging? If the answer to that question is yes, then these adjuvant studies, whether you deploy them earlier versus later, should pay clinical dividends, putting aside the toxicity and all the other issues that Rebecca just mentioned. If the answer is no, that we actually have to have that mechanism, on the table the way we see for SERENA-6, then maybe early deployment in the adjuvant setting is not the most fruitful exercise. So because I don't know the answer to that question, and because I do think, even though the studies aren't designed this way, that these drugs are probably at least equivalent in the wild type population, I don't have a problem offering this opportunity to patients. But we actually get into this discussion, the question you just asked, Neil, which is like, what do we know about how these drugs can work earlier and earlier without the mutation? And we have kind of a commentary around the lines of what we just said. I think the switch paradigm that we just saw is trying to kind of split the difference, right? To say we want to enrich a little bit for more heavy pretreatment so that there may be some of these subclonal ESR1 variants that are starting to pop up in that population.
So I will say that of all the data we gathered from the survey, the one I'm most interested in running by you and see what you think about it is it relates to SERENA-6. So to me, very interesting findings as I've been discussing with Seth and Max. But let's move on now and have Hope get into the issue of tolerability and practical issues with these SERDs. Hope?
So, of course, when we have new agents that we're incorporating into clinical practice, and we tend to almost always incorporate new agents into the metastatic setting first and then move them to the early stage setting, as we've been discussing, we have to balance the efficacy against the toxicity and tolerability. And then I think that what's really important as part of this is being able to manage upfront, understanding what the potential toxicities are, informing our patients, and both applying prophylaxis when appropriate, but also manage the toxicities that might occur proactively. We're lucky here that with these oral medications, the toxicities are fairly modest, and we're not seeing a lot of drug-drug interactions, so it makes it much easier. So what we're going to do is to jump into the toxicities of the various oral SERDs. Some have more data than others, depending on whether there's been phase 3 data reported. And I think we have to be a little bit cautious in looking at phase 1b and phase 2 data until there's an expanded population to evaluate. And I'll show you some of that as well. So we've already heard some about these toxicities in the previous presentations, but we've all looked at the discontinuation rates from chemotherapies, antibody drug conjugates, from adding targeted agents to endocrine therapies. And I think when we're looking at the adverse events in all treated patients, we look at, of course, if there are any deaths associated with treatment, which is not really an issue with our current oral SERDs, thank goodness, but we also look at dose reductions and study drug discontinuation and the rate of higher grade toxicities. Now, I think it's important when we're looking at higher grade toxicities to compare the experimental arm to the control arm and keep in mind that these patients have advanced disease, and so they're going to have some additional toxicities which are difficult to attribute to either the drug versus progressive cancer. And we discuss this all the time in a variety of settings. Here you can see that dose reductions weren't really an option for fulvestrant, but they're uncommon with elacestrant, and study drug discontinuation due to toxicity is also quite uncommon. And remember that these studies were done before there was any evidence that these drugs were better than the control. So that's an important concept. Now, after we've looked at that general toxicity, we want to understand what are the common adverse events. And I will say that when you look at these tables, look at the top or sometimes the footnote, because the way the adverse events are described is different based on the study. Some studies use AEs occurring in 20% or greater than patients, depending on the treatment. Some use 10%. And obviously, this is going to give you a different perspective on what the toxicities are. So, of course, we're looking at the elacestrant column here, where we're looking at grade 3, 4, and all grade. And what you can see is that nausea is the most common toxicity, but it's rarely higher grade. So generally, that's a good sign. The same with fatigue and vomiting. And it's interesting that all of these agents have been associated with an increase in fatigue universally. And then when we start adding on CDK4/6 inhibitors and potentially even more with drugs that target the PI3 kinase pathway, we see even more fatigue with the sort of an additive, what appears to be an additive effect. The rest of the toxicities seem to be sort of general and potentially not even associated with the drug. It's important to look at liver enzyme elevations because some of these drugs may cause liver enzyme elevations. We've seen that with the CDK4/6 inhibitors, but here you can see it's a rarely a higher grade, which is where it's really going to matter to us. And again, these patients have advanced disease. So really encouraging. When you look down the grade 3, 4, we're not really seeing toxicity. I will point out that we do not take in the toxicity of injecting a drug into the muscles of the buttocks, 2 shots every month and every 2 weeks for the first month. That just is not captured. I'm not exactly sure why. We're really terrible at capturing alopecia, but we just don't capture that well. And that's an important part when we're comparing fulvestrant that is really only taken into account with patient-reported outcome data. And I'll show you some of that as well. So there wasn't any difference in toxicity in this study and in any other studies. So this is the only data that I'll show you regarding looking in the patients who had ESR1 wild type, because, that was a question with this very first study, would there be a difference? And there wasn't anything. And then you can see that there were very low discontinuation rates due to adverse events, and antiemetic use was in the less than 10% range for elacestrant, and standard of care was actually higher, a little bit higher with aromatase inhibitors, similar, and very low as you would expect with fulvestrant. One thing I want to point out on this study is dyslipidemia, which was listed as a toxicity of elacestrant, and that's because they monitored it. I think that we've seen that patients who have higher lipid levels will have an increase with pretty much any of the hormone drugs that block estrogen or the estrogen receptor. And this was seen with elacestrant. You can see hypercholesterol, hypertriglycerides at 30% and 27%, but the rates of grade 3 and 4 were extremely low, 0.9% and 2.2% with hypertriglyceridemia. So that's actually specifically called out. And why does that happen? And it's thought to be due to changes in the liver production of VLDL, or very low density lipoproteins, which are the precursors to triglycerides. And it's something that, we monitor occasionally, and you want to know at baseline when you start elacestrant. We'll talk about that in just a moment. What about quality of life? So this is data from the EORTC QLQC30, and the scores were similar with elacestrant and standard of care. And remember, this was our first study with oral SERDs, so it did include a more heavily pretreated subpopulation compared to all of the other studies that we'll look at, which I think is important. And showing that these curves are completely aligned is very encouraging, and the quality of life as well, if anything, a little bit better with the elacestrant than with standard of care, which mixed together the injection and the oral aromatase inhibitor, so that you're going to see some variation there. And then what about when we combine elacestrant with a CDK4/6 inhibitor? We have the largest data looking at a dose escalation study called Elevate, combining elacestrant with abemaciclib. And you can see again that the toxicities here are really what you would have expected from abemaciclib. There's no difference in PK or PD, and no increase in the toxicities of abemaciclib or elacestrant, interestingly. So there wasn't an increase in nausea, which I think is really important, and no increase in diarrhea compared to what you would expect with abemaciclib. So that was very encouraging. And then we've also looked at elacestrant in combination with ribociclib and palbociclib. And I show you here this data, which is small numbers of patients and essentially shows the same thing with no increase in what you would expect from the CDK4/6 inhibitor combined with either an aromatase inhibitor or fulvestrant. And then lastly, although we're going to mainly focus on the CDK4/6 inhibitors, we also did not see an increase in toxicity with everolimus, but it was actually interesting that when we were doing a study in today's world with everolimus, everybody, the investigators, preferred to give 7.5 rather than 10 milligrams, which is immensely more tolerable. And remember, this drug preceded the Optimus approach of the FDA, and we might have ended up with a different drug dosing had we had that approach initially. So what about looking at imlunestrant? So imlunestrant was compared to standard of care endocrine therapy, and you see essentially low-grade diarrhea, 21%, about a fifth of the patient, but grade 3 or greater was quite rare. So that's also encouraging. The other toxicities are, as you would expect, you do see some nausea. I mean, I think anytime our patients are on these oral medications, they do have some nausea. I mean, rarely, and I think surprisingly, we even see nausea with the oral CDK4/6 inhibitors, even though that was an uncommon event. So I think that's always important to think of. You give something by mouth, you always want to think about, how you're going to manage nausea and give patients the tools and also instruct them to call in. There were no oral SERD specific safety signals, for example, no cardiac signals and no eye toxicity, which is important with our new classes of agents where we're seeing dry eye and keratitis occasionally. And then when you combined imlunestrant with abemaciclib, you see, of course, 86% of patients had any grade diarrhea. I thought the 8% of grade 3 or greater was surprising, actually, because I would have expected to see more diarrhea than 8%. So it's hard to know how people track this because occasionally people do have one day of, high grade diarrhea. But I think the big issue here is that grade 2 diarrhea is really bothersome to patients, but this is what we would expect from abemaciclib. There was no increase in neutropenia either. And then if we look at this discontinuations due to adverse events, what you can see is that it was relatively similar. Adding abemaciclib didn't seem to increase the discontinuations due to adverse events. There were significantly more dose reductions due to adverse events, and that was largely abemaciclib. And we do that when we give abemaciclib with just about any endocrine therapy. In any case, I think most of us would feel like we reduce the dose of abemaciclib in close to 40% of patients due to diarrhea in any case. And there was no excess in death. So that's actually very encouraging safety data. And then I show this slide really just to compare Monarch 2, and there will be more data, trying to do these statistical comparisons and combining different trials. When you're looking at abemaciclib and fulvestrant and comparing it to imlunestrant and abemaciclib across trials, across time, different patients, different setting, it looks relatively similar. So with all those caveats, that's encouraging. And then global health status, quality of life was presented at ASCO this year, and again shows very encouraging data with imlunestrant with an improvement relatively. You can see almost a 10-point change in the global health status, quality of life with imlunestrant versus standard of care endocrine therapy. So it's considered maintained, which is encouraging, and this is over time. So it doesn't get worse over time, but you do see worsening, presumably due to disease progression with standard of care endocrine therapy. And then what about looking at the specific symptoms? The symptom domains were broadly similar. You just see the worsening symptom domains where you would expect them in diarrhea, for example, appetite loss and nausea. So these GI toxicity is what we see. And I want to call out the fatigue. We're always going to see more fatigue when we combine agents. So we know CDK4/6 inhibitors added to endocrine therapy increase fatigue. And then what about camizestrant? So this is the initial data looking at camizestrant alone versus fulvestrant in a sort of dose-finding phase 2 study now published in Lancet Oncology. And what you can see here is that, again, there were relatively low dose, discontinuations due to treatment, very low here at both all three doses. And one of the doses was closed early, the 300. You can see only 20 patients. Dose reductions, again, occasionally, not very often in those 75 milligram arm. Dose interruptions occasionally. Again, this was a new drug being used. But what you can see is when we get to Serena 6, that once people were used to giving the drug, that this was quite uncommon. And then here's all the different treatment emergent adverse events. And one of the concerns with camizestrant when it first came out in phase 1b and then in SERENA-2 was the rate of bradycardia, sinus bradycardia. Interestingly, that seems to have gone away by settling on a dose that didn't really cause significant bradycardia and screening for EKG to make sure that people don't have baseline bradycardia. The other thing we always want to look at is liver enzyme elevation. You can see this is very uncommon. And we'll talk about the eye toxicity in just a moment. So here's SERENA-6. What about the adverse events leading to discontinuation? It's important to keep in mind that this was a double-blind trial, so people did not know what they were on. They were all taking 3 medications. And that's really important when you look at discontinuations. People didn't know. And you see the discontinuation rate from adverse events was very, very rare. The dose intensity was remarkably good, and it was uncommon to have SAEs. What about the specific adverse events that we saw? As you would expect, these patients were getting a CDK4/6 inhibitor. Neutropenia was the most common toxicity that patients had, and patients stayed on camizestrant and CDK4/6 inhibitor for longer, so they had slightly higher rates of neutropenia, presumably due to duration. What about other toxicities that are of note with camizestrant? What you can see here, this is 10% or greater. Patients were screened with an EKG, so if you had baseline bradycardia, you couldn't go on the study, but bradycardia was not seen, so that's very encouraging. But what was seen, which is intriguing, is photopsia. Photopsia is flashing lights when you go from a light to dark room. And, it's really interesting. It doesn't last long. We learned a lot about it. So photopsia is addressed in the bottom of this slide. There was no impact on daily activities. The visual effects had little activity. And it's very interesting talking to patients who have this. You go into the dark room, you have the flashing lights. It doesn't affect your vision and it goes away. And having eye exams over time, there were no eye impact. So no impact on the physical eye. You didn't get keratitis. You didn't have any retinal effects, et cetera. So that's very encouraging. It's a weird toxicity, but there you go. Otherwise, dry eye was also reported, but it was low grade. So there is some eye effect, but again, no lasting keratitis. And then vepdegestrant, again, we have the data from VERITAC-2 and low rates of discontinuation and dose reduction. There are mild liver enzyme elevations and again, all low grade. You see the fatigue with this single agent. Fatigue seems to be higher reported in VERITAC-2 than in some of the other studies with oral SERDs. Maybe they did a better job of collecting the data. My guess is that fatigue may not be very much different between the different oral SERDs. And then you can see this low rate of neutropenia, which is intriguing because these patients just got vepdegestrant alone. So this is something we need to look out for over time, because you also, the anemia is just due to cancer, but the neutropenia is kind of intriguing here, about twice, a little more than twice what we're shown with fulvestrant. There also in the phase 1b study, they uncovered this impact on P-glycoprotein, but they've been able to combine it with full dose CDK4/6 inhibitors without unexpected toxicities and didn't need to dose reduce, but you do need to be careful about con meds. So where are we in summary? So I didn't talk about giredestrant because we have the least amount of phase 3 data with giredestrant because, as you saw, there wasn't a difference in that initial trial, but we'll see a lot more data, I think, in the next year. There are differences in terms of the expected toxicities. Elacestrant's the only one that reported triglycerides. This doesn't seem to be a problem in clinical practice. There have been some enzyme elevations reported with giredestrant and now a little bit as well with camizestrant and maybe vepdegestrant, but these are very, very low rates. The bradycardia didn't really pan out with camizestrant to be an issue. And then I think all of these drugs cause nausea and vomiting. Of course, depends on the individual patient. I'm guessing there isn't a big difference. Diarrhea seems to be more commonly seen with imlunestrant, but is generally low grade than with elacestrant. So how do we manage these as we close here? In terms of the nausea, we have more data with elacestrant because that's our approved drug. So all of us have given this drug. Taking elacestrant with food really helps the nausea. It's important to keep in mind in the original trial, they thought there was a food effect, so you had to take it fasting, but it turned out you could take it with food. So if you take it with food, the nausea is markedly improved. And then making sure that patients have PRN antiemetics is really important. And olanzapine is my current favorite drug for nausea because you take it only at bedtime and it helps you sleep. And then it also helps your nausea during the day as well. Dose modifications are published for elacestrant. It's important to keep in mind that you can easily dose reduce. Tell your patients to call in. It's really important. Give them the tools to manage the toxicity, and then dose reduce early. These patients are not on a clinical trial. You can go back up on the dose if you feel like you were too hasty or patient's doing great and whatever their previous issue is has resolved. And here you can see the difference. And once you get to the 86 milligram tablets, very easy to dose reduce again. Quite rare, only 3%. What about cholesterol and triglycerides? Monitor at baseline. You need to know where patients start. And if you treat as indicated for rise, is very easy to treat, not an issue. And grade 3-4 elevations were extremely rare. So what about our general management of toxicity with all of these new agents? Varies depending on the agent to some degree. Taking the pills with food helped, varying the time of day. So for example, if you take it in the middle of the day, you're not eating anything, you're more likely to have GI effects than if you take it with breakfast in the morning. That makes it really easy. Treat the nausea. You can modify diet for diarrhea and give antipropulsive agents and reassure patients about photopsia that this is not going to cause any long-lasting eye toxicity. And also, there's some data that the photopsia goes away as you continue the drug over time. Baseline EKG is important with camizestrant because of this bradycardia, although we haven't seen it in patients who didn't have bradycardia at baseline. And then dose reduction for fatigue, I think, is really important, as well as for continued adverse events. No clear interactions with CDK4/6 inhibitors across the board, and we monitor those toxicities per routine practice. So just to briefly talk about this case, this is a 62-year-old who was on letrozole and ribociclib for metastatic breast cancer to bone for 4 years with excellent disease control. She now has progression in bone with moderate pain that's well controlled with NSAIDs. She has an ESR1 mutation on next-generation sequencing in blood and no other targetable mutations. She's very active. She's really afraid, and we see this a lot now with our patients. They're like, there's a lot of oral drugs. I don't want to be on anything IV. And I want to stay on really simple medication. I don't want to have diarrhea. I don't want to come in every month for labs. So they are really concerned. And with bone-only progression and relatively modest symptoms, elacestrant was a great approach for her. So she started on elacestrant with excellent disease control. But after 2 weeks, she called in and said she's been having mild nausea, but had been taking her medication at bedtime since that's how she remembered to take medications. So really on a almost fasting state. So we advised her to take her medications after breakfast, and her nausea went away without medication. So although she was given ondansetron and olanzapine, she didn't actually need to take them. 3 months into therapy, she had a recheck of her fasting triglycerides, which were high at baseline at the upper limit of normal, and she went up to 300. She was really worried about heart disease, although I have to say oncologists tend not to be as worried about heart disease in patients with metastatic breast cancer because of the lack of long-term impact. But in this case, we started atorvastatin, and immediately her triglycerides went down to normal, and she tolerated it well. She stayed on elacestrant for actually 8 months with excellent disease control. Was excellent, was really grateful for this respite. Thanks so much for your attention.
So thanks so much, Hope. That was a great presentation, interesting case. We're going to move on to the survey in a second, but just one question back to Seth. Again, I'm just trying to get more granularity about the GI issues with oral SERDs. Hope, I don't know whether she was saying it's not that much different than CDK inhibitor. I haven't heard much about CDK inhibitors and nausea. Seth, it was interesting. I was working with Erica Hamilton talking about Protax, and Erica brought up to me the question of whether or not the GI effects of the Protac, vepdegestrant, might be less than with SERDs. I know you've put some patients on the Protac, Seth, on clinical trial. Any thoughts about the GI issues with either of these?
Yeah, it's a great question. I mean, conceptually, the drugs are similar, but of course, there are some slight differences in their mechanisms and perhaps even some of their off-target effects. Anecdotally, I haven't noticed a huge difference in my own practice. Again, I'm thinking in all of the next-gen anti-estrogens I've given across oral SERDs, Protac, SERMs, I had one patient who was sick and kind of in rehab and had a lot of other medical issues and polypharmacy, who we actually had to dose reduce a SERD for GI, related stuff, predominantly nausea. I don't think I've ever had to stop or dose reduce anybody else. And in that case, there were many other contributing potential medications. So I'm not sure that I've seen it better or worse. And I think we have to learn a little bit more when patients are on it for a longer period of time. One thing I've noticed with abema is that, like neratinib, it tends to peak within the first like couple of months, and then it tends to trail off, and people tolerate it a little bit better over time. I'm not sure I've seen the same pattern with the anti-estrogens, as with this like early peak and then it fades off. A lot of times you can have this kind of persistent like symptom burden for longer. Maybe it gets better, here in Boston it gets cold, so the hot flashes might not be as bad in the cold weather, but then the joint pain gets worse, and vice versa in the summer. For you guys in Miami, the hot flashes are worse, but I don't sense it so much as a peak and then a drop as it is kind of a steady state. And maybe the PROTAC is different in that sense, but I'm not sure I've had personal experience to see the difference.
All right, well, let's move on now and talk about this survey. And as I mentioned, Max and Seth almost kind of wrote a paper in a way. There's a lot. We're going to show you some of their bottom line, and I have a lot more stuff that they wrote. And they kind of wrote it to me like the way people normally write a review article or a guideline. But because of the fact that we have more quantitative data, it kind of reminds me a little bit of the St. Gallen thing, where they try to get more quantitative about, is it really a consensus or maybe a little bit of a difference in how people approach it. And there are a number of situations here where that comes up that I'm curious for your thoughts of. So first, as I mentioned, we had 20 investigators, including the panel here today. And you can see we had very prominent people here. Noted Dr. DeMichel, who did the discussion of SERENA-6, was one of the people. We'll get into what people said. And also, Hope ran a program at ASCO, I think it was the next day after SERENA-6 was presented. People were still kind of digesting it. And I went back and looked at the discussion there. And also, we had surveyed the group there. And we'll share that and see whether, as the summer went on, people started to think more and talk more. But here's the group that we had. And as I mentioned, we also did a simultaneous survey of community-based general medical oncologists. See, these are the same docs who are taking care of, myeloma, CLL, bladder cancer, et cetera, our primary target audience. I'm only going to show you a couple of examples there, one where there's a little bit of difference and another that I thought you would find interesting. So let's talk a little bit about, again, these are some of the conclusions that Seth and Max made, and we might ask them to elaborate a little bit on it. But one thing that they picked up on, and this really, Rebecca, you got into this with your talk, was the timing for, the evaluation of biomarkers. And also, clearly, as you look at this data, it's quite clear that this is now a biomarker-driven strategy, particularly second-line therapy. But they picked up on the fact that people were evaluating this early, quote, in the patient's disease. I think initially there was a lot of thought about mainly focusing on second line. But what we saw actually was quite a few people, not the majority, but a number of people who said at diagnosis of metastatic disease, if the patient had, quote, hormone resistance, theoretically, you might want to see PIK3, but we didn't specify that. But I am curious, Rebecca, do you think in general at this point, again, particularly considering the possibility of the triplet, but maybe also in terms of ESR1, that these assays should be done on diagnosis of metastatic disease?
I really do, because I have a feeling that we are treating a lot of patients who have ESR1 mutated tumors at diagnosis based on prior aromatase inhibitor use, probably with aromatase inhibitors. And I think that we're probably missing the idea of triplicate therapy with inavolisib. Not that that is the easiest thing to give people or not, but it's really the way that I understand the tumor, and I don't expect that to be a general thing, as people aren't as excited by genomics everywhere. But I think that it's really important to see the changes over time as well. And so I think that testing at diagnosis and at each progression, at least until the chemo time period where patients are too sick and you can't really rely on oral medicines as much to control disease because of really profound endocrine resistance, I think that it's important that we kind of spread that knowledge all around the United States.
So, and again, Rebecca covered these, but we asked the faculty what kind of methodology they employ. A lot of people, the majority, go with circulating DNA, liquid biopsy. The rest do both liquid and tissue, assuming it's available. And generally, most of the people felt that ctDNA testing is more sensitive. And so, Francois, any comments again about testing? Also, I was interested, I think Rebecca talked about acquiring BRCA somatic mutations. I'm curious whether you've seen that, Francois, and any other comments about testing in the metastatic setting.
I think that Rebecca refers to PIK3CA at some point rather than acquiring BRCA mutations. So let's say BRCA mutations are supposed to be stable over time. PIK3CA mutations are very likely to be stable over time. So let's say in my practice, we are using the primary tumor or the tissue biopsy and metastatic relapse to really assess PIK3CA status. So because you have some false negative when you with ctDNA when you have low ctDNA level. So when it comes to PIK3CA status change at time of progression on CDK4/6 or later on, I would say that the change in PIK3CA status is likely to be minimal, and the reports that have shown a discrepancy, let's say acquired PIK3CA mutation, are mostly based on ctDNA. So which means PIK3CA was not detected at the very beginning of first line because of a low ctDNA level, and then was detected later on because of a higher ctDNA level. So, but when you look at the tissue, it's somehow stable when it comes to PIK3CA. We have what could be acquired is PTEN mutations, PTEN deletion, or AKT when you are using a PIK3CA inhibitor, because we know that will drive the resistance as ESR1 mutations are driving the resistance to AI.
So here's the second point we want to get into, and this is probably the one that we have the most data on. We're only showing you maybe about half or so of the slides, because we asked a lot of different scenarios. But again, particularly in terms of second-line therapy, here's Seth and Max's take on that. In patients with ESR mutant, a longer duration of first-line anti-estrogen CDK, and the presence of bone-only minimal symptomatic disease, because we asked a number of factors, including with visceral disease, that these are important clinical factors in terms of selecting SERD monotherapy over alternative second-line therapies. In terms of PIK3 mutant disease, the faculty investigators favor capivasertib and fulvestrant in the second line, and particularly including patients with a suboptimal response to first-line therapy with consideration of chemo or more likely antibody drug conjugates in more rapidly progressing patients. Interestingly, I'll show you that as we saw very soon after capi was introduced, very little, almost no use of alpelisib in investigators. We actually saw some in general medical oncologists, which surprised me. Here's the experience in terms of median number of times investigators have used these various drugs. Interesting how rarely, even though people say they want to use inavolisib, and I think everybody's accepted that in the appropriate situation because of the fact that not every patient is a candidate, or much less usage. But let's go through some of the scenarios. Here's a few with short duration on CDK and letrozole. So we made it less than a year as per the data that Seth was reviewing. So we say they get ribo and an AI for 10 months before they have disease progression. And then the question is, how would you manage a patient like this with different mutational profiles? So Hope here with ESR1 mutant, PIK3 wild type. Most people say elacestrant, but you see a number of other alternatives, including everolimus and fulvestrant in this situation. PIK3, no alpelisib here, only a capi and fulvestrant. But interestingly, here are the general medical oncologists on the same question, and actually about a third of them say they would use alpelisib fulvestrant, which surprised me. I see Hope shaking her head. I guess maybe and you're all shaking your head, so I guess you've seen this. And second opinion, it really surprises me, but if that's true, I think it's pretty interesting because we're always looking for situations where people are doing something different than investigators, and it seems pretty clear people have switched to CAPI. Now we still have the same situation of short time on CDK/AI, 10 months, but now you have symptomatic visceral disease. So how is this going to affect therapy? Now you see, even with an ESR1 mutant situation, a lot more people going to chemotherapy. Interestingly, capecitabine rather than an ADC, but also not so much in terms of SERD. For PIK3, again, CAPI and fulvestrant, really not chemotherapy, even though, again, symptomatic of visceral disease. But here's another scenario of a patient who develops metastatic disease on an AI after 2 years. Again, ESR1 mutation, and still elacestrant, most common choice, but you see a fair number of people going with other alternatives, including capecitabine or an ADC. For the PIK3 mutation, again, even though the patient has symptomatic bone mets, still CAPI with fulvestrant. Again, general medical oncologists, you still see a fair number of alpelisib, which to me seems a little surprising. Now we flip over to probably a more common situation of a patient who relapses after 2.5 years. So clearly over the 1 year barrier in terms of CDK and AI. Now, clearly here, when you have a ESR1 mutant, PIK3 wild type, almost everybody says elacestrant. People still say CAPI, fulvestrant in the PIK3 situation. Still, you see the same thing again with the general oncologists, a third of them using alpelisib. As we see in oncology in general, if we say age 80, even with a PSA1 and a few comorbidities, really, we could show you the data, but not very much a difference in terms of how people approach 80-year-olds unless they have significant performance status issues and comorbidities. So again, a situation of multiple symptomatic visceral metastases and 2.5 years on therapy, ESR1 mutation. We see, again, abema and fulvestrant pretty common, elacestrant as well, but a lot of variations. When you do guidelines, you try to summarize these things, but when we see data like this, we say maybe it's a lot more heterogeneous than we expect. You don't see that in a guideline. The fact that you go to 4 different doctors and you may get 4 different treatments, and yet you can still say a majority have X. And again, CAPI seems to stay in there with a PIK3 mutation. We thought this would be interesting. Second-line endocrine therapy in a couple of situations where now people are getting targeted treatment earlier. So now we're saying the patient's getting the triplet first line for PIK3. I was curious to see whether anybody would follow up with CAPI. I assume not. And in fact, even though 3 people did say CAPI, most people said they would move on to chemotherapy in a patient who gets the triplet second line, at least with a 10-month disease-free survival. We move it up, progression. We move it up to 2 years. We still see a lot of heterogeneity in how people would approach second-line therapy in patients who have the triplet. And then finally, in terms of the first-line setting, we were curious how people would approach patients who had adjuvant CDK. So if they had adjuvant abema, for example, as in this scenario that we put here, would first-line therapy for metastatic disease kind of look like second-line therapy in patients who didn't get CDK? And that's pretty much what we found. ESR1 mutation in the first-line setting, people said elacestrant if they'd already had adjuvant CDK. Again, in terms of second-line therapy here after adjuvant abema. Interestingly, a fair number of people say the triplet with inavolisib in that situation. Others say CAPI with fulvestrant. Let me just stop there because that was a lot to digest. There's a lot to talk about. I want to start out with Seth because you guys wrote a whole lot about what I just talked about. Maybe just kind of summarize what you think are some of the most important findings that I just presented there, Seth.
Yeah, thanks, Neil. The way that I thought about this data, and Max really did a great job sort of characterizing the amount of cohesion or discohesion, from the different experts here, is that when you're in these extreme situations, it's fairly straightforward. So the patients who had the long frontline therapy, ESR1 only, everyone is sort of pushing toward elacestrant. The patients who are PIK3CA, ESR1 wild type, or who had more endocrine refractory disease, everyone is pushing toward Capiva. It starts to break down when it gets a little more complex, meaning their time on the frontline therapy isn't as good or as clear cut, or it's in the middle, or somebody has a dual mutation. And I think this is where you start to see the example like you just gave us, where across 20 doctors, there literally are almost 4 options that are equally distributed. And I think it's really complicated when patients have multiple actionable targets. And then when you move into the last couple of scenarios that you talked about, we are really in uncharted territory. So what to do after adjuvant abema is one of the most complex questions right now. We have absolutely no data and no prospective trials in that population. What to do after triplet, a Nova 120 regimen, also completely uncharted territory for the same reason. And I just wanted to come back to a point that Francois-Clement just made a few minutes ago. The difference between these truncal, both germline and truncal somatic mutations that don't move around a lot, where you can kind of test like green eggs and ham anywhere, anytime, anyway, and you find it, right? Solid, liquid, early, late, doesn't matter, versus the acquisition of specific things. And so, for example, somebody on a Nova 120 who might acquire that P10 or AKT mutation, I would seriously think about, trying to offer that patient something like Capiva, because they're still probably dependent on the pathway, and they have demonstrated that through their updated ctDNA. Same thing with ESR1, right, where they're still ER dependent and they're acquiring that ESR1.
So, Rebecca, I'm curious, where you have one or the other mutation, short or long progression-free survival, what stood out to you? And I think I saw a couple people shaking their head yes about the fact that people are still using alpelisib, which I think is kind of interesting. But of what you saw just now, Rebecca, what sort of stands out to you as maybe something that would be useful to focus on?
Yeah, so when I think about the double mutant patients, I go back to the Emerald trial data. And if you look at the subgroup analysis, that for patients who were in their sort of endocrine sensitive, longer time on pre-CDK4/6 inhibitor therapy, when you had double mutants, there was still benefit to elacestrant when given to those patients. And so we do know that that drug is active even if there is a PI3 kinase mutation. And certainly quality of life wise, it is easier to tolerate elacestrant than it is of something that targets the PI3 kinase AKT mTOR pathway. And so in a patient who's minimally symptomatic and maybe had a longer time on their CDK4/6 inhibitor, I certainly consider elacestrant in those patients. I don't rule it out just because the PI3 kinase mutation is there. Historically, there's this idea that, these patients that have the PI3 kinase mutation are very, very aggressive disease and we have to use stronger drugs, but not in all of them. And so if I have a time where I could provide them better quality of life and sequence the drugs that way, I certainly consider that. Now, in someone who is super symptomatic, and especially, and this is a really important point that Dr. Wander raised before, in patients where you see like 6 ESR1 mutations, that's more a sign of a very unstable genome, highly aggressive, often luminal B cancer, where maybe the elacestrant is not going to work so well. I do tend to avoid elacestrant in those patients that have symptomatic liver disease with multiple ESR1 mutations. And even if there is PI3 kinase and ESR1, those are not necessarily my pick. As far as alpelisib, I think that is a reflection of the time it takes to change practice patterns and comfort level with drugs. I mean, all of this is relatively new as we think of the time course over which these drugs have been available. In 2019 is when we got alpelisib. It took a while for people to start using it. They get comfortable with that. I don't know if anyone can ever get comfortable with alpelisib because it's very toxic and very difficult. But if they got used to that, the idea of switching out when they saw good responses, probably for capivasertib, which is a new one they have to get used to, might be kind of daunting. And there also is this idea that I've heard that targeting a PI3 kinase mutation with a drug that is PI3 kinase specific versus the AKT inhibitor may influence some practice patterns that way. We're not necessarily seeing that in the data that you can't target a PI3 kinase mutation with an AKT inhibitor that's downstream. But I think those may be possible explanations for the alpelisib uptake in the general oncology community.
We'll take a look at the data that we pulled or got with the double mutant, but I just want to focus first on what we just talked about, Hope, which is patients with a single mutation, either ESR1 or PIK3, which is what we just went through, both in patients with visceral disease and with short or long time on CDK and an AI. I'm curious, I hope anything that stood out to you in terms of these single mutations, in terms of what people chose to do, and also when you pull out the ADC or capecitabine as opposed to even going to hormonal therapy.
Yeah, I mean, I think the second part first, I think it was surprising looking at the survey to me that, like, for example, somebody chose datopotamab deruxtecan as sort of second-line therapy for a patient where we don't even have first-line data with that drug in that patient population. So, and I think it's really a completely different thing for a patient to go on IV therapy with nausea and, some albeit mild eye toxicity and mouth sores. I think we don't have data to support that approach. But I also think that it's hard for practitioners now, particularly as Becky was mentioning, those who are treating more than one cancer. I just don't know how they keep everything in their mind and what they're going to do in clinic when they're faced with a patient in front of them with a 15-minute appointment is choose from what they recognize. So that's what I think happens. Something that looks new and shiny may be good. But for choice of treatment. So, for example, you were talking about single mutations, right? If you had just an ESR1 or just a PIK3CA mutation, I think that, the issue for some patients is if you have a PIK3CA mutation and you've been on your first-line therapy with the CDK4/6 inhibitor for 2.5 years, and I think, Seth could speak to this as well as Francois. Not all PI3 kinase mutations are the same. And the variant allele fraction may play a role that we don't even really understand because we expect the PFS to be shorter. You still get the same hazard ratio of benefit of a CDK4/6 inhibitor in that first line setting, but we expect the PFS to be shifted lower. But for some people, they stay on for a really long time, and it doesn't appear to be associated with this specific mutation. So there's something else going on there, some modification that we're not understanding well. So if somebody's been on for a long time, has minimal progression, you might even consider changing the CDK4/6 inhibitor rather than starting on the AKT inhibitor right away. Most of us are not going to give alpelisib because we believe that capivasertib, as Becky mentioned, is a relatively better tolerated option. But alpelisib is very effective for people who don't have access to capivasertib around the world. And, you can manage the toxicity in most, just not all. It just requires a lot more work. So for most people with a mutation, we're going to offer them capi fulvestrant. For ESR1 mutations, our decisions are going to be very much dependent on how the disease is progressing, the patient's symptoms, and how long they stayed on first-line therapy. We have, there's a lot of data. The drugs and combinations aren't approved yet. So we have this sort of whole panoply of information to put in, but we can't use it yet in clinical practice. And one of the things I think that people are very interested in is, elacestrant is a drug people have been giving. So can they combine elacestrant with different agents? And we have the Elevate data, and I have actually seen patients receive elacestrant and abemaciclib, for example, which seems to be well tolerated without PK/PD issues, and was effective, albeit in a non-randomized smaller population. So you can do this, and I've seen patients get that treatment. We like combination therapy rather than single agent therapy, but we also need to balance this with toxicity, the patient's clinical situation, and the patient preferences. This has to be shared decision making over time.
And also cost. So let's get into the double mutant situation. This is one of the things I was most interested in seeing, because ever since this became an issue, we've seen a lot of variability depending upon how we present the scenario. So again, here's the summary from Seth and Max about this. They call it a data gray zone, for which multiple biomarker-selected therapies are approved, and provider preference for using single-agent SERD versus capi and fulvestrant was impacted by patient and disease-specific characteristic, as Hope was just alluding to. Endocrine monotherapy favored in those with longer duration on CDK therapy and bone-only symptomatic Mets. But here's the way it actually played out in terms of the numbers. So again, this is a situation of a quick development of progression at 10 months on ribo and letrozole, double mutant, and people generally go with capivasertib, although Rebecca was bringing up the fact that we have data on elacestrant in a double mutant patient, and I don't know that we do have data with the capi population, but maybe somebody can correct me on that. But in any event, in this situation with a short interval on CDK, people would go with the capi and fulvestrant. And again, with we bring in visceral disease. Now you're starting to see capecitabine coming in there, but other than capecitabine, again, you still have capi and fulvestrant. Interestingly, again, you see more alpelisib come popping up in the GMO survey. And then when we get into the situation now of a patient, again, doubly mutated, but who was on adjuvant and anastrozole, again, doesn't seem to have affected things the way people responded very much. But now we move out to, again, a more common situation of a later relapse after 2.5 years of therapy. Now, with a double mutant, the most common selection here is elacestrant, as opposed to what we were just talking about. And again, in an 80-year-old patient, still elacestrant, a little bit more maybe because of toxicity considerations. But interestingly also, we say now, okay, it's still 2.5 years, they're double mutated, but they got visceral Mets that they're symptomatic from. You see people flipping back to capi and fulvestrant. And then, again, double mutated situation on having had adjuvant and anastrozole. And again, you see a split between capecitabine in this situation and elacestrant. And then again, getting back to people who've had the triplet, who've been on therapy for 2 years, still have the PIK3, but have a new ESR mutation. You see one person saying capi, but most people say elacestrant, and a fair number also saying capecitabine. I don't know if this is too much to process, in your brains, but again, in the first line situation, now the patient having had adjuvant and anastrozole, this is the situation of endocrine resistance where the triplet would be indicated. Most people say the triplet, but not all in this situation. Some say capi with fulvestrant, which I think is pretty interesting. But Seth, I'll start with you. How do you take all these data and tell us what people are doing? Or is there a lot of heterogeneity and a number of options really can be considered?
I think the latter, comment there is true. And I wanted to come back to a question you just raised, which I actually think, Neil, you hit the nail on the head. The biggest biomarker question in this patient population right now is how the dual mutants did on Capiva, right, on Capitello 291. We do not have that data. It's a huge data set. And I will say, to the point that's been brought up a couple of times today, I think the oral SERD data, especially as a monotherapy, the teams have really done a great job of putting this all above board and showing us what's happening to the ESR1 plus PIK3CA patients, for example, on Emerald. And we have data from EMBER-3, and now we're generating real world data. We have a couple of abstracts coming up at San Antonio this year looking at large real world clinical genomic data and multi-site institutional data to try to answer, Neil, your question, which is what happens when you have an ESR1 mutant on AKT inhibitor therapy. The second piece of that is what are the resistance mechanisms, both intrinsic and acquired, to AKT inhibition. We're going to start to see a lot more data on that, both institutional, real world, as well as lab modeling that many teams, including ours, are working on. Without that data, it starts to become really hard because Rebecca, really showed us how valuable it is to be able to look at the Emerald data and say, well, the people with PIK3CA, they might be doing a little bit worse overall, but they're still clearly gleaning benefit from even oral SERD monotherapy. And I don't think we can confidently say the same from capivasertib yet. I think the finer data, if I remember correctly, with IPAT, showed a little bit with the ESR1. And then we had a phase 1 study with IPAT in triplet combination. And we also showed that a maybe preliminary signal, right, that the ESR1 people aren't doing as well. And it's so hard to make these decisions if you only have half of the biomarker data as we're talking about today. And I think that's partly why you're seeing this heterogeneity. People are trying to use patient age, patient comorbidities, diabetes, et cetera, state of the disease, speed of the disease, to do the best they can with an incomplete data set to choose between these options.
So, Francois, I'm curious how you think through, again, assuming all options are available to you, how you think through the doubly mutant patient. I have to say, again, just sort of sitting here thinking about it, because we've brought this up so many times, but people focus a lot on the efficacy data, but you all have brought up, including in these cases you talked about, tolerability issues. There's a pretty significant difference in tolerability to elacestrant and oral SERD versus capi fulvestrant. But for practical purposes in your clinical practice, Francois, how do you think it through?
Well, let's say, the result of the survey are very interesting. It's showing a high heterogeneity, between faculty and also among general practitioners. Let's say, I fully agree with what we know. It's like, we have like these single agent sets, very convenient, very easy for the patient. But as soon as the disease look a bit more aggressive, less endocrine sensitive, or, we probably would move to, targeting PIK3CA pathway if there is any mutation there. And obviously, we often prefer combination versus single agent, as pointed out by Hope. If I may, I just want to also to raise a point that, we have these, multiple answers because we have no very satisfying answers. None of these treatment options are very satisfactory. We have short PFS overall, like 6 months PFS. If you look at the subgroups, then you could get your 9 months PFS. But this is coming after a first line with 2 year, 2.5 median PFS. So that is quite deceiving, I would say, from a clinical perspective, after CDK4/6 inhibitor, where patients were doing super well. And the elephant in the room here is the arrival of trastuzumab deruxtecan. And there will be a lot of pressure. And the ESMO guidelines have been revisited this summer, and they are really, pointing out at the use of TDXD as a second-line treatment right after CDK4/6. So which means, all these endocrine therapy combination in the second-line setting will be kind of crushed by, TDXD probably getting, a significant part of the prescriptions. And then, the next debate we should have next year maybe is how to navigate between, staying on endocrine therapy, whatever the agent or the combo, or switching directly to TDXD. Most patients are HER2 low or HER2 ultra low in the ER+ setting. And obviously, I think that all of these treatment options are going to be, let's say, simplified because TDXD will come and take, a significant part of the market. So for all patients with an aggressive disease, we'll probably start with TDXD. That's what I assume currently. And then, think later to another line of endocrine therapy. But if we were to run currently a trial, TDXD versus second line endocrine therapy, whatever you put facing TDXD is likely to be inferior in terms of PFS, and likely, I would say also, it could be also inferior in terms of OS.
So I actually want to skip on to the Serena 6 thing, because I really think it's maybe the most interesting thing here. And here is Seth and Max's summary of what we saw. And again, when you write a review article or guidelines, you kind of focus on what the majority think, but it's also very interesting to think about the minority. So they kind of came up with the same overall global kind of conclusion as from the discussion at ASCO by Dr. D. Michel, that it's kind of not ready for prime time. But when you actually look at what they said, you actually find that, the majority say it wasn't for prime time, 13, but 7, some pretty prominent people, including 3 out of the 4 of you, said yes, that it is. The data does support using this strategy. And interestingly, the general medical oncologist, 2/3 of them said that they wanted to do it, as opposed to 1/3. So the majority saw the Serena 6 data, and in spite of the discussion, still would like to use that strategy. We asked, how often. Then we presented 2 scenarios. Now we're back to the investigator. So we say, 1, the patient after 1 year on ribo and anastrozole is found to have an ESR1 mutation. And again, the majority of people would not switch, but 5 would. And again, oncologists even more say that they would switch, 50%. Now we say it's 2 years that the patient was on ribo and anastrozole, but they developed ESR1 mutation. And again, 6 of the 20. So the majority say no. And I don't know, this is exactly what I was expecting. Hope, again, you got into this 24 hours after the data was being processed. We had asked people prior to even seeing the data what they thought they were going to do. And at that point, most of the answers were, I'm not sure. A couple of people already had decided they wanted to wait for PFS2 data. And Joyce O'Shaughnessy, even then, was saying, yes, I want to do it. Any thoughts, Hope, again, in terms of thinking about this as a strategy? Even general oncologists are even more positive about it. I kind of assumed that everybody was following the Dr. D. Michel thought about it's not ready for prime time, and now I'm not so sure. What do you think, Hope?
I think that there's a lot of aspects to this which are quite interesting and complicated, just like a lot of our data sets now. So remember that this population of patients had to have very endocrine sensitive disease. They defined it as being no progression at 6 months into therapy. And surprisingly, they actually identified an even more endocrine sensitive group than we thought. And I think that we've been motivated by the fact that patients who had a new finding of an ESR1 mutation and scans that didn't show progression still stayed on that therapy for 9 more months, which was really unexpected, I think. But if you look at the quality of life data, so you go on study, you do your paperwork at the first scan, and then after that then they were stable. This is a short period of time. After that, big fall off. So what we're going to see at ESMO, I believe, is at least I've been told, that the domains of the quality of life scores. And I think this is going to play a really big role. One of the things that plagues us in the evaluation of metastatic hormone-sensitive, hormone receptor-positive disease is the inability to really detect progression early by scans. So these patients had pain. Their pain changed. It was much better with the switch than without. So that would affect how we would incorporate that. My assessment of that is that probably these were patients who had progression, but you can't see it on scans. And changing made a big difference in their quality of life. We all want to improve patients' quality of life, along with helping them to live as long as possible. But in the absence of survival data, quality of life has a big impact. So what would we do in clinical practice? And if we assume that potentially the big difference was pain and that impact, because I can't imagine what else it would be with quality of life. We have to wait to see the data in a month, but it's a really interesting question. if that's the case, then you take your patient, they have oligometastatic disease, they showed up with an ESR1 mutation, you might wait to change. Patients who have a lot of bone disease or are symptomatic, those are the patients I would change right away. And then there's going to be some gray area in there also that we're going to have to decide. I think when we do the testing is also going to be important because people seem to change based on looking at the data we're inferring to some degree. We tended to see the ESR1 mutations around a year and a half in this very endocrine sensitive population. So maybe you wouldn't even check until after a year. Because Francois himself has shown that you get sort of the mutations or you don't, like the people who stay on for a really long time, they don't get mutations. I don't know, who knows that? Maybe Seth in his later years will figure this all out for us. But we don't understand why some of the cancers just don't ever get an ESR1 mutation. And the ones that do, you tend to find it in the earlier time frame. Remember, there was, a lot of patients, almost 2,000, who never got a mutation during their follow-up.
It was interesting. Dr. Michel used the term molecular progression. And I was thinking to myself,
Yes.
all these people are going to progress at some point. It's not like, we talk adjuvant colon cancer that some people don't develop metastatic disease. Everybody here is progressing. It's just a question of when, and particularly related to quality of life. I want to get the other faculty's input on this question also, but I just want to ask at this point to Hope, take a deep breath. And I know you've seen a lot of data fly by here, but I'm just kind of curious in general, what do you think that we're so far in terms of what we've shown you, which I think are really the most important questions here, in terms of this specific issue, Hope, in terms of SERENA-6, to me, what's the message that you get from looking at the data? To me, it looks like people are kind of viewing this differently. What's your take on it?
First of all, it's a really cool thing that investigator-initiated study led to this big phase 3 trial, and what I think information that will change our thinking about the treatment of metastatic disease. So kudos to Francois for putting an enormous amount of years and effort into this. I think that we're going to have to continue to see ongoing data with the quality of life scores. For me are really important. What happens in the real world in terms of when we start seeing ESR1 mutations, further studies with change of CDK4/6 inhibitor. I think there's a lot of interest in could you use ctDNA and not just the mutations, but maybe even the variant allele fraction to determine when you do scans. Patients are always saying to me, like, do I really have to do a scan every 3 months or 4 months or 6 months? And some of our HMOs will do scans so far apart that you're missing the progression and they're too symptomatic. It's brought up this whole question that didn't exist before, which is, I think, a really important question that maybe Francois will help us answer in the next 5 to 10 years. What we're going to do in clinical practice, I think, will continuously shift as we get PFS2 and eventually OS data from this trial.
It sounds, from what I heard from Hope, that she would like to have the option available for some patients, at least, who develop, as we're talking about, molecular progression. What are your thoughts, Francois?
So I would say that as a beginning, it's a beginning of ctDNA implementation. It's in the journey. So now we have a tool that can, let us know in advance that the patient will experience a disease progression. And what is interesting is to look at all clinical cases that have been, discussed at symposium or by the faculty. And, each time the patient progresses, we have to explain what is the general condition, whether the patient is symptomatic or not. And what is very attractive for this strategy is that, again, we are transitioning from one treatment to another, but before, the disease progression. And again, if an investigator knows that a patient developed an ESR1 mutation, but choose not to switch the treatments, then, what is the justification? A few months later, if the patient developed a symptomatic disease progression, how could you justify not having switched before? I think it's really speaking to people like practicing a lot, and experiencing people coming back to the hospital with a lot of symptoms, and you don't want to see that. We are very attracted with the first line treatment. When you see your first line patient, most of the time it just takes you, like 5 minutes, and half of them will be just to ask them about their family and how was Christmas and so on, because there is nothing to say they are doing well in first line. And here, it's again the idea of transitioning and trying to extend that good time for the patient. So that, I think that it speaks to the basic oncologist, I would say. And when it comes to the, let's say, KOL or trialist, it's more about the strategy, whether what are the PFS in second line, should I wait or not? But then when you wait, a lot of patients, and it was 1/3 of patients in the control arm of SERDs, these patients were treated with chemotherapy as the next line. And it's really showing that, you are losing some patients. So everyone is referring to the steep curve, at the very beginning of all Emerald and other trials. But what is very appealing, and what we have to remind, is that 1/3 of the patients won't even make it to this Kaplan-Meier curve, because they will have to be treated with chemotherapy as a next line. So that's very important to keep in mind. And so that's, let's say, very friendly for the patient as well.
Becky?
So I'm going to be honest, I was the one who said it was not ready for prime time. And I'm going to say my interpretation of prime time was part of the reason, because to me, that means insurance is going to cover this, and that we really have no indication of that. Like community oncologists tell me now that they're getting patients with giant bills who, had their ctDNA checked in the first line and things like that. So as far as disseminating this and just telling everybody they should be doing it, I'm very conscious of what that would mean to the patient as well. And the other part I just want to point out is that as far as quality of life in this trial is concerned, it was a very highly international trial, and these patients, many of them, did not have the option to get an oral SERD off of trial, and they self-selected to be on a clinical trial. So these are highly motivated patients who want to have everything done. They want to have their ctDNA checked and feel like they're getting the closest monitoring, but that doesn't necessarily represent all of the patients that we do see out in the community. And so I think it's to be interpreted, the quality of life data, a little bit with caution, because I think it's a bit more complicated than what you're seeing from cancer Olympians on a clinical trial always. But I would want to make sure that we have mechanisms in place. I mean, many of us researchers in this, we have agreements with some of these companies that we do these ctDNA testing, and it benefits both of us as far as research. And, we know how to deal with it if the patient does get a big bill. But in the community, that might not be the case. They don't have the time to fight these peer-to-peers. And this is sort of the reality of oncology, is if you look at how bills get dealt with and denials get dealt with in the community versus in academic institution where we have a whole team of people to help us, fight denials, it can be a little bit different. So there's just some practical concerns that I think need to be addressed before I would say this is ready for prime time.
So, Seth, any thoughts?
Yeah, let me start with the last part. And Francois-Clement knows how I feel about the concept behind SERENA-6. I'm a big advocate for this idea of personalized medicine and precision oncology. And I think one of the reasons, Neil, and I was surprised also by the data that you were showing from the community setting, I think patients love this idea. I think clinicians inherently like the idea of getting ahead in the way that Francois-Clement was just alluding to, of symptomatic progression and meeting the patient where they are biologically, right, at any given time. I had a couple of thoughts on SERENA-6 and the really interesting question that Hope brought up about the dynamics of ESR1. For SERENA-6, and I briefly mentioned this earlier, and we recently wrote an editorial on this in one of the Nature Review journals. The 53% of patients came onto the study at various times after 6 months. Could have been 18, 24, 36, whenever. 53% of the patients had ESR1 on the first draw when they first entered the study. Now, to me, if we had started monitoring earlier, you could have caught that ESR1 2 months, 4 months, 6 months earlier. So when you think of the PFS1 at approximately 7 months, I think it's a dramatic underestimate. I actually think it could have been a year plus. And so as much as I want to see PFS2 and OS, I still think it's all underestimated, right? The biology is real. The data is solid. Whatever we're seeing there is actually an underestimate of what the true primary endpoint would have been if we had caught half of the patients 2 to 6+ months earlier. And I think to the point that Francois-Clement made just a minute ago, this is the beginning, right? Not the end. This is like the jumping off point. There are so many ways to iterate upon this and build upon it, add different genes, design, the study in slightly different ways so that we're crystallizing our understanding of the true magnitude of benefit. And then to Hope's point, which is a really interesting one, and this is data that I was honored to be the discussant for when Francois presented it in Munich at ESMO Breast, when they looked at PADA-1, where people were being monitored kind of more evenly over time, you see this bell-shaped curve where the people at the front, the people who progress early, you don't see ESR1 there. And that makes sense to me. They don't have time to get the ESR1. They came on to their, frontline CDK with a RB mutation or a KRAS activation or an FGFR or a PTEN or an AKT, and they progress. They don't need ESR1. There's no evolutionary pressure on that tumor to develop ESR1. And then all these people in the middle, kind of slowly but consistently, starting at about 8 to 12 months, you start to see these ESR1s pop up, and they tend to just keep popping up over the next couple of years. And then to Hope's point, on the end, it trails off. You have these people who are doing okay for a long, long period of time, and they don't get ESR1. There's something about the biology of that tumor where they cannot or they do not acquire ESR1. I have less of an understanding or even a hypothesis as to why the late, people can't acquire it. The people in the middle make good sense to me. The people in the front who don't get it make good sense to me. I think we need better tools and better biologic models to understand that. So I'm very enthusiastic about the data from SERENA-6 as a starting point coming from PADA-1. And I think there's so many more interesting questions we can learn about other resistance mechanisms and other targets. And just to close, Neil, on the whole survey, I think we're seeing a lot of really interesting areas of both consensus and kind of lack of consensus, right? There are clearly some edges where we can say almost everybody's kind of approaching it the same way, whether it's in academia, KOL, whether it's clinical investigator, whether it's community doctor. And then interestingly, in some of the areas where there's more discrepancy, we're seeing some differences between, general practice providers and clinical investigators. And I think we can learn a lot by highlighting those areas and saying, we need maybe better data here. I think we need maybe better subset analyses from some of these trials.
So final comment from Francois?
Yes, so just to come back to Seth's comment, regarding the incidence of ESR1, so the data are quite strong about few mutations being detected during the first 6 months on AI plus CDK. In PADA-1, we have also decreased later on after 30 months. So what we see is a decrease, and it makes sense in the terms of the mutation being selected. So which means if after a given time the mutation has not arisen, then it was not present from the beginning. If it's a subclone that is selected over time, after some time, it won't appear anymore because it was not there from the beginning. That's what is happening in KRAS for colorectal cancer. But having said that, the data is very frail because in PADA-1, we follow the patient from the beginning, so we have very few patients at risk on that side of the bell-shaped curve. So we are waiting for SERENA-6 to confirm or infirm the results.
This concludes our program. Subsequent to the recording of this program, the FDA granted approval to imlunestrant for patients with ER-positive, HER2-negative, ESR1 mutated, advanced or metastatic breast cancer with disease progression after at least one line of endocrine therapy. The approval was granted on September 25, 2025, based on data from the EMBER-3 trial. Conflict of interest statements for the faculty can be found in the program notes, and during the program, the use of agents and treatments that are not approved may have been discussed, so please check out the package insert information for more. Special thanks to the faculty, and thank you for listening. This is Dr. Neil Love for Striving for Consensus.